पैसा पनि तिर्नै बाँकी छ
ए गर्नु बाँकी हो सर
भने
यतापट्टि
होइन म त्यहाँ रिसिभ गरेर म पेपर उसमा गरिदिन्छु मेसेज गरिदिन्छु डक्टर उसलाई है त डक्टर सुशीला आउँछ साथी
पार्किंग में छु यार निकलो ना
Thank you, everyone.
To try and make this society even more stronger in the future. This year we've given the emphasis for the conference on global surgery. So I'm going to be talking about global surgery and where we stand in Nepal. Can I have my first slide, please? Okay, before the slides come on, what we want to understand is, as surgeons, it is not only the role of a person who treats, but we also have to play the role of a leader, of a social person, and try and bring about change. And that is exactly what global surgery is. Global surgery is what WHO defined as one of the sustainable goals for 2030. And it looked at, when it looked at the health impact of the world, it found out that surgery, wait, that's something? Right there. Yeah, I know that. Okay, so as I said, are we really living our role as surgeons? It's something that we really need to question ourselves and to see that whether we are doing what we actually need to be doing to our people. Because as surgeons, we are a different breed of personalities. Those of us who go into surgery are a type A personality, and yes, whether we like it or not, egos do play a big role in our lives. And we always try and want to do something that somebody else hasn't done, and we're trying to prove that we are always better than the others. But is that actually what the role of a surgeon these days should be? If you look at this, global surgery is a component of global health. And when WHO looked at this, it found out that surgery was the most neglected part in the healthcare of the world. In fact, this article very well coincided as the stepson in the surgical, in the health fraternity. So surgery, in fact, is a branch that is really not looked upon anywhere in the world, let alone in Nepal. And it is something that everybody thinks that surgeons are out for themselves and not for the community. But if you look at the 10 most global causes of death, we are third. We are the cause of deaths of our patients in the post-operative period. And that's because we will always want to blame it on somebody else. But as leaders, it is our responsibility, and we are the ones to be blamed for these deaths, whether it's directly or indirectly. Now, if you look at this article saying delivering safe and effective surgical care across the world is one of the greatest challenges facing global health today. Because you've got to see the standards of healthcare is very variable throughout the world. And the whole idea of global surgery is to bridge that gap between the haves and the haves not. Even amongst the haves, what they've done with their resources is actually, if you look at it, very outlandish. They've put in a lot of money in research and high-tech technology, but when it comes to patient safety, even in the West, I will show you data which has proven that global health is not as what they would want to believe. So what should we actually be doing? We should be creating a value for the patient, where it is patient-centric, where we lower the cost, we improve their patient care safety, and it should be a global healthcare improvement around the patient and not around our needs and our desires, but rather around the patient. So what is global surgery itself? It is a matriarchal group authorship. So what does that mean is that we should actually promote people who are good, and we should be promoting those to come on the top. It should be a snapshot methodology, align projects to clinical needs. Any hospital in the world must belong to the global network so that you can help each other. Just like the SARC Surgical Care Foundation is another global network that I'm a part of and I'm the president of. And it is our view that we should try and help our neighboring countries and ourselves to, in fact, enrich our knowledge. As part of SARC, my friend Dr. Dulanta is here from Sri Lanka, and Sri Lanka is very ahead as far as data collection is concerned. Global surgery should be. So if you look at this article again, it says it's a multidisciplinary interface between surgery, anesthesia, and public health. So along with surgery comes public health as well as anesthesia, because if you look at the perioperative mortality deaths, around 30% of deaths is attributable to anesthesia but these anesthetic deaths can actually be prevented. And majority of these anesthetic deaths happens in what they call the low-income countries, and it is our countries that can actually bring a big change in global surgery. So when you look at what are the things that can be done, first of all, you've got to start building safety standards, the NABH or the JCI. Now, maybe in Nepal we will not be able to do the JCI, but we could do what India has done with the National Board of Hospital Accreditations. We could have a similar accrediting board in Nepal that actually could certify and look at the patient safety and compliance of all these hospitals and try and bring up the standards. So we should have patient safety or oriented hospitals. We should have the WHO checklist in place. We always talk about it, but when I go around Kathmandu, only 18 hospitals. You know that Kathmandu has got more than 99 hospitals, 99 or 102 hospitals. Only 18 hospitals comply with the WHO checklist. Regarding our data, how many of us are actually procuring our data and saving our data to actually analyze ourselves for our betterment? And that is also something very lacking in our part of the world. Infection control committees, drugs and pharmaceutical committee, blood transfusion committee, amendment boards, tumor boards, training and accreditation committee. All hospitals should make it mandatory to have this on board. The hospital I work, Medicity, fortunately does have all these committees, and they do ensure that we go and abide through these rules. Now, if you look at the mortality of emergency and abdominal surgery in high and middle income countries, it's not a big surprise that in the low income countries improve. Again, death after surgery is 3 times more likely in our part of the world than in the developed world. This is not me speaking, this is a very good article from Reuters, which is published in 2018, which has clearly shown that yes, perioperative mortality is more likely in a low-income country than in the developed world, and this is something that we should be looking into. Now again, it's a mindset, as I always say, is how many of us, like yesterday I stated, what is the percentage of laparoscopic hernias being done in our part of the world? And I showed in my data yesterday, and it was again by Dr. Ramesh Punjani in his data showed that even in the West, in a country like America, the total amount of laparoscopic hernias is mounting to around 48%. Sweden has the highest number, but otherwise even the Great Britain, all across, they're around 27 to 30%. Germany is the only exception where they have around 78% of their hernias are done laparoscopically. Nepal is close to around 10%, very close to India, but if you see our neighboring countries, that's even less than 10%. So are we actually justifying this treatment for our patients? Hernia though, is just a small hernia. Well, in reality, if you look at your reality check, laparoscopic hernia is not costlier than an open hernia. Of course, the initial investment of the instrumentation and the training of the surgeon is costly, but in the long term, if you look at lap appendectomy or lap hernia, it turns out to be much cheaper. Professor Dr. Paulinivelu, who is with us today, and he'll be giving an oration, he always speaks about why lap hernia is more essential for our part of the world. Again, this slide shows that in lap appendectomy, the incidence of infection, surgical site infection, everything is lower, even mortality is lower if done laparoscopically. But if you look at the amount of lap appendectomy done in low-income countries, it is actually only 0.21%, 0.21%. So it's a dismal number throughout the world, whereas we surgeons don't seem to worry and care. All we worry is what big surgeries that I can do to boost my ego. So it is high time we start retrospecting ourselves and saying, are we actually fulfilling our role as a role model and for the nation and for our own people? What we want to understand is who we are treating are Nepalis, Bangladeshis, Pakistanis, Sri Lankans and Indians. So we should be actually retrospecting into our data and looking into this. Again, another thing that we don't seem to care much about is the use of antibiotics and surgical site infection. You know that just 3 days, last week was around 8 days back was World Infectious Disease, and the WHO has taken out surgical site infection after gastric surgery is high in high-income, middle-income, and low-income countries. When they looked at it, we were the worst. The low-income countries were the worst as far as SSI was concerned. And I don't think it has got to do with the armamentarium in a hospital, but it is our mindset. We do not have a protocol and we don't believe in the ethos of protocols. We need to have trainings. We need to retrospect M&M meetings and of course data and error disclosure. This habit of not disclosing, especially in our Asian community, is a big drawback. We've got to start recognizing that and go ahead. So as this article, although it's very old, we need to understand that mistakes do happen and we have to have, and the 5 reasons for mistakes is inadequate data, inadequate practice of guidelines and protocols, culture of blame. We've got to stop witch hunting and pointing fingers at each other and need to compensate the injured patient mentality. No, we do not need to compensate, but we need to change our culture. We need to change our practice, and that is most important. And in the end, the difficulty of truth telling is something that we need to start doing. So take home messages, I put it in very bold, is please let's put a condom over our egos. As surgeons, whether we want to believe it or not, we have to do that. Let's practice safe surgery, change our culture. Let's stick to WHO, stop witch hunting, stick to protocols, and strengthen our weakest link. That is the most important. We will always work as a chain, and we will have weak links throughout our chain. And we've got to go and look into that weak links and try and strengthen it. Thank you very much.
Thank you and have a good day. Until the conclusion of these sessions, to access the DA schedule, kindly scan the QR codes on your identification card. I also request the presenters to visit the preview room before proceeding to your respective hall. Allow me to delineate the guidelines for the session. Presenters are requested to kindly adhere to the time allocated for their presentation. For a 15-minute time slot, presenters are allocated 3 minutes for question and answer session, while for a 10-minute time slot, 2 minutes are for question and answer session. The initial bell will sound 3 minutes prior to the conclusion of the allocated time, followed by a second warning bell 1 minute before and third bell indicating the conclusion of the designated time. Presenters are expected to bring their presentations to a close promptly after the sounding of the bell. Any questions are to be entertained strictly within the allocated time for the questions and answer session. The first session focuses on safety in laparoscopic surgery, and it will be presented through a video format. Without any additional delay, I'd like to extend an invitation to the esteemed chairpersons of this session to take their seats at the forefront of the room. The designated chairpersons are Ramesh Panjani sir, Pradeep Vaidya sir, Baburam Pokhrel sir. With this, I hand over the session to the esteemed chairpersons.
For his wisdom contributed to my journey in laparoscopic surgery. Please welcome.
And respectable chairpersons, my gurus and colleagues. The topic is safety in laparoscopic surgery. I want to start my bumps and bruises that I had to come across during my career. I'm still a practicing surgeon, so probably next time I'll be presenting my hematomas and fractures in practice of laparoscopic surgery. So to start with, in fact I'm representing all the surgeons of my era and my time, what we went through. And it's not only my story, I'm sure those surgeons and my colleagues of that time who were with me in my same boat, we went all through the same story. So, in fact, I'm representing my era and my colleagues of that time. And I started my laparoscopic surgery somewhere in mid-45. I was young, and I was at that time, I was 45, and that was not my mistake. And I was young, and other my colleagues were even younger, even more young. So age is just a number. So it's never late. That's what I wanted to convey. And the time when we started this laparoscopic surgery, somewhere mid-early 90s, that was the time it was looked upon very skeptical, and it was very hard to convince. And that was the phase of denial. Not the ordinary people, even in our fraternity, people didn't believe it, and it was taken. Don't know how it was to start something when there was nothing to get reference as. If somebody would have told me that, in 2023 we'll be doing all this advanced laparoscopic surgery that you guys are doing these days, I would have thought it must be science fiction or just a big dreamer. But hats off to you guys who have brought laparoscopic surgery from that age to this age now, and the things you guys are doing. And in fact, you guys have brought our dreams to come true. Thank you very much for that. So this is where it was not done in one day. It took quite a long time, but we reached here. So I'll just briefly explain the flashback. The thing where we went through. Because if you want to understand how privileged you guys are now, you must know how we came up to here, abroad. But we're very rich with our enthusiasm and imagination. And I must be grateful for the surgeons of those days, the feeling of camaraderie which we had then. We should go for laparoscopic surgery in Nepal. So it was something somewhere in '95, mid-90s, when laparoscopic cholecystectomy was being done more or less regularly. Please don't ask me who was the first guy to do laparoscopic cholecystectomy in Nepal. It's a bit controversial topics, and I have already got a lot of friends in our fraternity. So one thing for sure I can tell you, it was not me. But that time we did whatever we could. Even at the 1990s, there was already a minimally invasive surgery dedicated hospital in Kathmandu. By name, it was minimal, and the hospital size was also very minimal, so we were never noticed. But by 2000, in a regular basis, laparoscopic urology was laparoscopic. And even gynecology is also good. Gynecologists were already doing laparoscopic tube ligation even in 60s and 70s. But in clinical aspect, they also started in 2000. It's a laparoscopic assisted vaginal hysterectomies, cystectomies, that kind of thing. And other landmark I must mention is the skill workshops, which is, I think, very crucial, and was started in 2003. It also has got its history, I'll tell you later on. And laparoscopic abdominal hernias, maybe around 2004. And then it goes on and on. You guys know it's better. We, the surgeon of that era, we did our best. We have got no regret. We couldn't take it in a jump, but whatever we did, we are very proud of it. And I'm very proud of my colleagues and my gurus, those who really supported them. The whole theme of my talk is this slide. I don't know why every word starts with E. And I'll be talking all these hurdles that we had to come across. So it starts with easy. If it was easy, economy, in education, equipment, ergonomics, environment, enthusiasm, embarrassment, and egos. Economy, I don't want to remember this topic much previously, sorry, easy, if it was easy. We're very naive when we thought that, yes, now we'll start our laparoscopic surgery, we'll change the whole system and we'll be doing this and that. But my illusion didn't last very long. As soon as I came to, as I had to face other things as well, the first thing was economy. All the hospitals, they hadn't got any separate budget for laparoscopic gears, training and things. And we guys, most of us, we had just started our career, living in a hospital quarter or a rental flat. Kids were just had started going to schools, and we were broke. So to come across, it was very difficult. It's not that banks could believe on us. Even our relatives and colleagues didn't really believe. But that was the stage we had to come through. And now the other hurdle was the equipments. Now I don't, and at least we started our surgery. Out of this all equipments, I don't think nothing is going to kill a patient during surgery except this guy. This endosclerosis, which is, I think, whenever you operate, your one eye has to be focused on insufflator. I'll tell you incidents. I was operating a simple laparoscopic cholecystectomy. Nothing was great there. There was some leakage, and I asked to increase the flow rate. I don't know if it was the wrong command or the faulty instrument. The flow rate was never ever seen. It appeared to come to normal. It took at least 3 days. So this is what I have learned, and I think you should also know about it. Today there is this is ergonomics. It is the most underrated, not appreciated kind of thing. It took me decades, and it cost me my neck pain, stiff soldier, tennis elbow. I realized that in fact, ergonomics. Tomorrow there is going to be a talk about this ergonomics. In the same hall, I highly recommend, please do attend it. And this is the slide that you will see tomorrow. We all know about it, so I'm not going to elaborate. And I mean, what should be the angle of your knee, what will be the level of table, and blah blah. So you will find it tomorrow. But the message I want to give is, it's a very simple thing. At least this much we can manage. It doesn't cost anything, and it does a great help in your ergonomics. At least we should be smart like this. This is not rocket science. We just don't give enough attention for it. And now the other E is education. What we suffered then, I'm sure you guys are very privileged. Most of hospitals have got that skill centers now. And most of medical colleges, they have got gurus who can teach you. But in our time, it was another hurdle. And yes, one of very few of us had some training abroad, and but it was contained within us, and there was not a platform to disseminate, and it was not taken that seriously. And surgery you don't do yourself; the team has to be there. But that also took some time to recognize that if you want to continue a good surgery, the team, the whole thing has to be on the same boat. Anyway, 2003, when we started our first skill program, and though it couldn't continue continuously, there was a lot of other hurdles, but anyway, we did it. But still, now what I feel lacking is we train only the doctors, only the surgeons. But doctors and surgeons itself, they don't execute the surgery. The paramedics, they are also another forgotten part of our training, which we should never forget. And these are the people who really makes our surgery successful. So there are places where we have started, I think 2 or 3 places where we regularly train paramedics. So the environment in OT, another hurdle I felt when we were coming out is everybody is a guru there, and there is no harmony among the staff and among the team. So there should be only one captain on the boat, of the ship. And when there are many gurus, everybody is throwing their knowledge, trying to prove, yes, he knows it's better and this and that. So in the boat, if the whole team is not thinking about the same surgery, and anesthetist is thinking about the next surgery, and a couple of the staff, they are thinking something completely different, the things doesn't go well. The other, you have to do it regularly. Morning you wash your teeth, brush your teeth, by evening you have to do it again. So embarrassment, I think I can write a book on this. So many cases, in your time, you will come across. It doesn't matter how long you've been working. It doesn't matter what system you are working in. But this is the thing not going to leave you as long as you practice surgery. This one case, I'm sorry for the picture quality. This one case, it was just we're thinking to abandon the surgery or do just partial cholecystectomy and come out. But slowly, gradually, we did it, and we're very happy when we could do total cholecystectomy. Though it took a couple of hours, and it was safely, it was done. We all were happy, but our happiness didn't last for long. As one of the scrub nurses said, "Doctor, one of the gauze is missing there." So, with putting our finger crossed, we went and we looked for it. We couldn't find it. Then I asked one of my other colleagues. He came. I was very scared to even chase the thing over there. I didn't want to have any bleeding. And my colleague, he was more bored. He went and he looked everywhere. He didn't find anything. So finally, I asked for another colleague. He also came and he also tried his luck, but we didn't find it. We couldn't find the gauze. So finally, we decided to convert it. We converted. We looked. We put all our hands, looked everywhere, and finally we decided, okay, better we'll close it, and whatever consequences will come, we'll face it. Then at that moment, our anesthetist slowly said, "Guys, you've been recording this case. Personally, I do record every and each of my case. Why don't you review your videos and see if it is really missing there?" So that's what we did, and we found that there was a count mistake, not any gauze was left there. I didn't know what to do with this anesthetist. She could have told a long time back. But anyway, thanks to her, And this is another thing, whole team has to be there. We all have to be in the same boat. Again, these hurdles and hurdles, if you have noticed, this last one, I don't know why its size is too big, and it doesn't fit in the frame as well. So just because, then I realized, because this is the ego, it doesn't fit. It always has to be bigger than the rest of the other letters. So this is one thing we really have to be consider it. Oh, I'm sorry. How you go back? Ego is bitter, very difficult to swallow, but we got to do that. Like Einstein said, is equally popular as E equal to MC squared. Ego equal to knowledge, 1 divided by knowledge. So we got to know it. We got to believe in it. Okay. Now, if my hurdles to start with, I think I can continue going on and on. But if out of young guys, if anybody will ask me, okay, doctor, you tell me one thing in 1 minute, the message I should give to you for safety surgery, definitely I would say, please do record all your operations. Because these days, even cheap equipments, they have got the recording device. You record it for your own purpose. This is going to help you in your medical litigations, for your academic purposes, and top of all, your reviews. Like, it has saved my life quite a few times. So, okay, I'm right on time. Otherwise, I had a few other, my embarrassment to explain. As I said that I'm a practicing surgeon, definitely we'll meet again, and I will tell you more and more of my embarrassments. Hope I will have not. Thank you very much.
Please welcome.
Good morning. Good morning. I'll be going through a short preview of things by how we can make cholecystectomy safe. So I do not have any conflicts of interest to declare. So we'll be going through patient selections, board placements, what is the standard of care, good judgment, when not to go for serious conversion and surgical timeout, and identifying difficulty and further learning about cholecystectomy. See, when we start cholecystectomy, this is especially for youngsters who are after finishing the surgery, they are going for cholecystectomy. They are going for laparoscopic surgery in an entirely new setup. You see, when we start, patient selection is one of the most important things. We often miss simple things like clinical examinations. So I recall a case that we had posted for cholecystectomy, and the resident he appreciated a lump in the abdomen. So who would go at night and examine the patient? But then we did further investigation, and it turned out that the patient had a CA colon, and then the whole thing got done. So we need to look for small things. The another thing is hernias. So these patients might have subtle umbilical hernias, which might prepare us to identify, especially scars as well, so that we can plan our post-port replacement and not be in stress when we start surgery. Similarly, we should always try to review the investigations. Even subtle changes in liver function tests might need further investigation. We should have repeated investigation until we get the right result, or the further investigation to rule out that we do not miss anything at all. So we should have a very low threshold for MRCP. So some minor changes in LFT, further investigation, if it turns out still there, it is there, get an MRCP done so that we do not end up in trouble. So we always prefer Hassans. It has been safe over the years, and during port placement, we just identify go by layers and layers, layers by layers, identify the peritoneum, inside the peritoneum, and then put the trocars. So the tab block is what we invariably do in all of our cases. It is a very safe thing. It helps us to know where our trocars will be coming out, and it gives proper analgesia to the patient as well. So we inject the local anesthetic in the transversalis plane and create a bleb and then insert the trocar. So it is always so we plan our ports. So usually for the epigastric port, it is safe to go at the lower edge of the liver, see for the spot, and then identify the spot by transsimulating, confirm that it is well below the GP sternum, and then create a bleb at that spot. So you can plan the direction of your trocar, and you will know beforehand where your trocar is coming out. So at this epigastric port, if you do not appreciate, sometimes in fat patients you might be going through the falciparum and injuring the vessels. So you should be careful about this. So for the other port placement as well, it is always safe to follow this. See where you are coming out, and then going. Similarly, while pressing the trocar, as we had been taught by Cockrell sir, it is always safe to go for axial rotation and not to push deep inside, so that you do not, and always keep the index finger at a safe distance so that you do not go deep accidentally. Similarly, triangulation is very important in laparoscopy. Otherwise, if you are planning a difficult cholecystectomy, you need to be prepared for suturing, so you should plan your port placement adequately. So what constitutes standard of care? You see, we should always, once we put our trocar inside, the first thing we should always do is appreciate the anatomy. We are always in a hurry to take out the gallbladder. So first step back and look where we are. So most of the errors they are due to visual perception, so misidentification of the duct, inadequate traction, retraction, due to inflammation of bleedings, and incomplete dissection of the cilia's. So technical mistakes are quite rare. So we should always try to appreciate where we stand and then only proceed. So there are certain landmarks that are very important. So the right portal pedicle, we should always stay above it. There is revia sulcus, there is falciparum ligament, and the epicholedocal plexus and the duodenum. So we should identify these structures and appreciate that we are in the right place and the right angle as well. So these are the 4 landmarks that we should always appreciate before we start dissecting. So anomaly is the norm in biliary surgery. So most of the time there are always some subtle anomaly. So we should be always prepared for that. So common things are short cystic ducts, aberrant hepatic arteries, and the right hepatic artery crossing anterior to the common hepatic duct. So dissection. So the basic thing is always stay close to the gallbladder. So whatever you dissect, always take to the gallbladder and tear down the peritoneum. So there is something called triangle of safety. This is the cystic, this is the cystic artery, and this is the lymph node. So when we dissect the peritoneum, this area is regarded as the safe area. So we should stick to that area. And however, distance we have, however length of adhesions we have, it is always safe to stick close to the gallbladder and way above other structures. So posterior dissection is one of the most important part. What posterior dissection does is it lowers the hilar structures way away from the gallbladder, and we get adequate space when we dissect from anteriorly. So most of the vessels and other structures, they lie anteriorly. So when we do adequate posterior dissection, we get adequate length for dissection of the cystic duct. So whenever we do posterior dissection, we stick close to the gallbladder so that we do not injure the vessels and cause unnecessary bleedings. So documentation is very important. So critical view of safety has been identified as a very important entity. Clear the hepatocystic triangle of all fat and fibrous tissue. Take down the lower part of the gallbladder of the cystic plate, and to see that only 2 and 2 structures are entering the gallbladder. So infundibular technique might be misleading. So we should stick to the critical view of safety. So there is something called intraoperative timeout. So when we achieve critical view of safety, we should always reconfirm with our colleagues, even the anesthetist or other staffs. So we should always get a double view. So both anterior and posterior views of critical views of safety before we start clipping them. So these days they are coming up with artificial intelligence which identifies the quality of the critical view of safety and can give you feedback. Hopefully in the future we will have machines which has incorporated that system into the whole thing. So is the critical view of safety the only acceptable means of ductal identification during laparoscopic cholecystectomy? So critical view of safety, the evidence is level 4. They have been doing routine cholangiography as well. Infundibular technique has been described, and visualization of the common bile duct and common hepatic duct, and even top-down cholecystectomy has been described. However, none of them are foolproof. Cholangiogram, there are a lot of fallacies. It is quite expensive, not available in most centers. It does not prevent injury, it helps to identify injury. And even in ductal injury, 80% are misinterpreted by surgeons as normal. But whenever we are suspecting cholecystectomy, then it should be used. And in 15 to 20% of the cases, it might not be possible to do a cholangiogram. And many injuries occur when we attempt to do cholangiogram as well. So when we are learning as a young surgeon, it is always advisable to ligate the proximal part of the cystic duct with a silk. So it will help to enhance your suturing skills and tying skills as well. And you take out the gallbladder and appreciate the integrity of the knot. And once you are well versed in that, then you can go for subdural cholecystectomies. You can do suturings and advance forwards. So distally, it is always advisable to ligate if the duct is edematous and if the duct is quite wide. Before clipping the cystic duct, once we isolate the cystic duct, it is always advisable to see further if there are any stones in the cystic duct. Many a times, we do not appreciate that, and we clip it, and we end up with retained stones in the cystic duct, which might be troublesome in the future. So identifying the cystic plate is also important. So whenever we identify the cystic plate, we also stick towards the gallbladder, have adequate traction. We will see lateral fibers coming up and stay at that plane. So once we stay at that plane, we do not perforate the gallbladder and we do not injure the liver as well. So unless you do have adequate traction, if we go for dissection, we will end up with injuring into the cystic plate and then causing liver injuries and unnecessary bleedings, because there are always some vessels inside the cystic plate. So when you have a difficult gallbladder and you need to protect the duodenum, it is always advisable to put a gauze bridge and push it down so that the energy devices do not injure the duodenum. So we should not be refraining from this whenever it is necessary. So there are certain rules of good judgment. These are proposed by sages, and one is the pausing rule. So when you appreciate that a 10mm clip is not adequate to completely ligate the cystic duct, you should pause and try to rethink that it might be something else as well. So if there is unexplained bile leak, if there is prolonged dissection without progression, if there are you are requiring more clips, and if the intraoperative cholangiogram is unclear, so we pause and we try to think again about the anatomy and the orientation and other things as well. Next is stopping rule. When do we stop? This concept is being used in aviation and nuclear power plants, and this is proposed in surgery as well. So when identifying risks and triggers, and when CVS is not achievable, we pause. And the third is call for help. When the anatomy is unclear, when complications are identified and when conversion is necessary, we need to call for help as well. So there are three good judgment rules. So more important than CVS, when not to go for CVS. So when not to go for critical EFCT, when there is acute cholecystitis with distended gallbladder, when there is genital granulomatous cholecystitis, when there is Mujiji syndrome in the case of large stones. So when we try to achieve CVS in this case, we end up with injuring the common hepatic nerve. So when dissection approaching zone of significant risk, halt. Dissection is stalled, conditions are difficult, anatomy is unclear, surgeons feel uncomfortable, and assistants with high skills are needed, and when there is possibility of other injuries. So conversion is not failure, it is part of the surgery. So this is a case where there was impacted stone and the So in difficulty, we should be going way up at the Hartmann's, opening up the Hartmann's pouch, taking out the stone, and then tying up the remnant. So this is what's component of the subtracheal cystectomy, the reconstitutive type. In these cases, the cystic duct might be absent and the stone might be, it could be a Mujiji and the stone protruding into the common hepatic duct, or the Hartmann's might be plastered to the common hepatic duct. Conversion to open, prior to conversion to open, choose exit strategy. It is safer to put a cholecystectomy tube rather than converting. Prior to conversion to open, drain placement might be necessary, or we need to go for subtotal cholecystectomy. And indication of conversion might be when patients are unable to tolerate pneumoperitoneum, when there is excessive bleeding, or when there is inability to perform suturing. So we should not be converting to better assess a suspected bile duct injury unless immediate definite repair can be done, such as hepatic regectomy, and better we should be placing drains and referring the patient to a center. To continue dissection when signs of need for exit strategy are evident, it is not adequate. If not adequately experienced in open cholecystectomy. So this problem is being seen in the West, where to do open cholecystectomy they have to invite a hepatobiliary surgeon because there are few open cholecystectomy being done. So this is one of our patients who was a biliary cripple. He had all spectrum of biliary injury, and ultimately he's doing good. And this was published in one of the journals. So CSS has a safe cholecystectomy program and regarding stopping bile duct injuries, and it is always advisable to go through that. Thank you.
Then that's going to in fact give you more difficulty during safe laparoscopic cholecystectomy. There are two things that I always say that you should try and do, and one is if you've got ICG, then use your ICG. Of course, if you don't have ICG, then you're stuck with it. But you will ICG. In fact, these days is one of the best tools to have to do safe cholecystectomy. The other thing that is available throughout the world is something that Professor Khanna from Lucknow has propagated, and I'm also a strong proponent of it. Is what I call cholecography. So in all our operative rooms, we will have a colleague next to us. So do your laparoscopic cholecystectomy after the consent of the colleague. So cholecography is in fact a scientifically proven method of doing safe lap cholecystectomy, something that I've been practicing now for the last 15 years, and we've in fact published our results as well, and it is something I would encourage everybody to do, is to do cholecography. Thank you, Biko. Thank you very much.
Thank you very much. Firstly, I am very humbled by the invitation from the Association of the Surgeons of Nepal. And hi, I am Dr. Ishant Kumar Chaurase, and I bring greetings from India, from the centralmost part of India, that's Bhopal. And I'm very humbled with the warm hospitality being given, being provided. And thank you so much once again, the President of the Nepal Surgical Society, the secretaries, and all the office bearers. So my topic for today is pneumoperitoneum. How to create a safe pneumoperitoneum. So ladies and gentlemen, you must be very well aware of this picture. It is a chakra view. So pneumoperitoneum creation, safe pneumoperitoneum creation is just like a chakravyuh. I think we should go in detail on how to break chakravyuh bhedne ka rahasya. Let's discuss over it. For this presentation, I always thank my friends, my mentor Dr. Sarfaraz Beg, and all my friends, Dr. Priyam, Dr. Nidhi, Dr. Sudesh. We all work together everywhere in India simultaneously. So I always give credit to my friend that what Dr. Sarfaraz Beg calls us the mastikars in India. So starting with that, what is a pneumoperitoneum? It's a pneumatosis, which is abnormal presence of air or the other gas in the peritoneal cavity, which is a potential space within the abdominal cavity. We all know the creation of safe pneumoperitoneum. It's a closed Veris needle technique or the open technique, direct trocar insertions, optical trocar entries, or a lateral lift technique. The instrumentation is required. We all know we require a carbon dioxide cylinder and its content connecting hardwares. We should know our insufflators very well. We should check and recheck, and there should be a standby unit in place. We should always prefer to use an HMEF filter. Strict aseptic precautions have to be followed, and Veris of all sizes should be available if we are using a Veris needle insertion technique. So Veris needle importance, see, initially it was invented to drain the abdominal cavity. We all know it has got two parts, the needle and the stylet, and there's always an eye on the needle. The diameter is around 1.2 and 1.8 mm. The maximum possible flow is 2.5 liters per minute. In pediatric, we use the 8 centimeter one, in adults, the 12, while in pediatric cases, we prefer to use the 20 centimeter. And of course, the disposable Veris needles are also available. So, understanding the Veris needle is very, very important now. Also, now there is a medical litigations following the Veris needle injuries. So, safe insertion is very, very important. So as you can see, Veris needle has got two parts to it. Firstly, there is a lock. Now this lock, when you close, the air doesn't go inside. When you open, as you see, the air starts to go inside. First, checking and rechecking on the Veris needle is very, very important. You can see that there is an eye to it, and we should always prefer, before inserting, we should always check. We should open it up and see that the stylet is working. There is no any other thing present over it. The proper function of the stylet and the eyes is there. After checking that there is no problems in the device, we recalculate it, fix it, and it should always be done by a surgeon, not by the assistant. Always remember this thing. It's our instrument. We are on the patient. We are checking the eye, we are checking the flow, and once we are affirmed, assured that everything is in proper functioning, we start to do the Veris needle insertion technique. We feel the resistance. This is very, very important. The resistance, whether it is working or not. Sometimes it doesn't work. So you can see that there's a blockage, the air is not going inside, the insufflation is not happening. So to avoid it, just have a check beforehand. Now, similar things for the disposable Veris needles. The technique, the check remains the same. We see for the eye, we see for the stylet, but always remember to check for the markers. You see a green marker, that means it is free right now. So this is the green marking that comes. And you see that there is no resistance is there. If there is resistance, the marker will change. This is a very clear indicator for it. Right now it's free. Now assume, as it will come to a resistance, the marking will change. The green turns into red. That means you are with some resistance to it. So again, checking is very, very important. This will avoid the complications. This will have the smooth start of your surgery. The start is very, very important. Now I have the checklist. We should always palpate the abdomen first. The bladder should be empty, especially for beginners starting with laparoscopic surgeries. Nasogastric tube placements. Position of the placement is very, very important. The position of the surgeon is very, very important. The ergonomics. Side and the alternate side for the insertion should be prepped for the insertion. Now here how I teach my residents at my medical college. So how to make the space is very, very important. So here the surgeons are performing, and I was about to tell my postgraduates, see, abdominal wall is in very close contact with the viscera. So always remember, this is my point which I've decided I'll put my port, I'll put my varices. So, always remember, grab the two recti, grab it up, lift it up, and then pull it away. One should always follow, whether as a beginner or as a seasoned surgeon, always this is a very basic thing. Grab, pull, lift. Why? Because it will always increase the distance between the two recti, and there will be a space creation which will help for the insufflation of the air to go inside the CO2 part. Now I am taking this video from the internet, one of them, the TV site. The safe varices. Why I am emphasizing on it? It is a very, very medical legal indication of various complications. It can be catastrophic and dreadful. So the two hunches which we hear is when we pass the recti and we pass the peritoneal layer. So how we insert the various needle once again? So since I have decided to put the position of the patient is determined, this is I was planning to do a TLH case. So this is my marking which I had said, the supraumbilical incision once again. So again recheck. This is second recheck before inserting. Hold the varices like a dart. We should always hold the varices like a dart. Always remember. I still follow the principle. Grab, lift, pull the abdomen. One holding like a dart. I can see one click, one resistance beyond power, and then the second one. So that means I have penetrated into the peritoneum. A safe various needle insertion, a good beginning for any laparoscopic surgery. Now this is, again, we should always follow, especially the beginners and the postgraduates who are present over here. So, the eye, the stellate, it's very, very important to understand. We pierce into the subcutaneous tissue, we have a barrier where the resistance comes, where we first hit that resistance is the linea alba. Now, again, the principle remains the same. Where do you feel the first resistance? It is at the linea. Now, once we go to a linea alba, there will be a resistance. Just a single click, a stellate will pass through it. That means we have crossed the first barrier. The first resistance is free of. Similarly, you will feel a free space. Yes, it's going nicely. Again, you feel resistance. The second resistance is that of the peritoneum. As soon as we hinge it up, as soon as the stellate comes back, the eye goes inside, and you can start with the insufflations. Now these various tests, yes, as a seasoned surgeon, we do not do these tests. Let's be very practical enough. But especially for the beginners, especially for the postgraduates who are learning the laparoscopic surgery, young surgeons, at least we should do these 5 tests. It's very common. I think routinely we all do the percussion test, just all tap the abdomen, but this is also very, very important. The suction test, the irrigation test, the hanging drop test, the insufflator readings, and the percussion test. Now how do we do it? After inserting the varices, it's very simple. Taking a small saline 10 ml or something or so, we just absorb it. If there's any injury to the bowel or to any of the arterial part, we'll see a red color blood coming out or any of the spillage part coming out. So, and then we irrigate it up. Again, we can just feel what if we have done anything or not. Now, ideal gas condition, we should have the limited cystic absorption of peritoneum, the side effects, the rapid excretion is there, high solubility is there. These are the characteristics of an ideal gas. What are the advantages we all know? This of CO2, it does not support combustion, it is highly soluble and well eliminated by the lungs. Now, as in the first lecture to describe the importance of all these things. So it is very, very important to know our chamber, the gas, what is the gas in cylinder, how much pressure do we want, how much flow we want, how much gas is done, how much pressure do we have right now, and the importance, and the HMEF filter. So quickly going through it, we should always check, as a surgeon, as told in the first lecture, one eye before starting surgery should always be at the insufflator part, which is the right pressure, the right insertion, whether we are going inside out, and then our final test comes is that when the abdomen gets distended, we tap it. That is the percussion tests. Other than these, the alternate sites for the insertion of various are the palmer's point, that the right subcostal area, the right lower quadrant parts. We do the open axis techniques, that is the Hassan cannula part, or the umbilical catastrophic part. Just take 2 minutes to finish it up. So the open technique, I generally don't do open technique, so I don't have my own video for it. So this is how we draw a line, the open Hassan technique. Like the Hassan's cannula, we identify the linea alba. Taking with the artery, we see the parietal peritoneum part. Again, we dissect it very gently, cut it with using fine scissors, and then insert the trocar. Similar goes with the umbilical methods, how we go through it. Now, this is the optical entry which I generally prefer. I generally prefer to use the optics. So, always return, we should always twist, hold the abdomen, twist the parts, and then gently go through the optics. Optics is a very safe thing to be used these days, rather than using a safety trocars. Now, after the new pattern checklist, diagnostic laparoscopy as in the standard fashion, more safety, never leave anything for seeing at the end. Now, this is something which I really love to see. Abdominal complications, we all know the extra-abdominal emphysema, subcutaneous, or intra-abdominal can be, which can be catastrophic, the whole organ injuries to all the viscera, the bladders, the pneumoperitoneum, and trocars injuries are very, very devastating. They are medico-legal, very implicating as well. 40% of these cases. Now, these are single cases which I see the various needle injuries which have to be avoided now. Now, as you can see, it has penetrated into the bowel. So, what to do? Do not panic. Remember the rule of the one. Close your eyes, think what has to be done, take a suture, repair it up. Sometimes can be more catastrophic. Again, so the importance of laparoscopic suturing routing again comes to the picture. That this is the injury of the bowel. Don't panic. No, we convert to laparotomy. Okay, if you are a skilled surgeon, if you are a good MIA surgeon coming into it, do not panic. Even if you are the best of the best surgeon, follow the rule of one. Close your eyes. Look, search. There's enough time. If not, call for help. If you are there, then do it up. What if we face a scenarios? What if you face this after a various insertion? What will you do? So much fecal matters. Many of you will think of converting into open. Absolutely not. Give a nice peritoneal lavage, identify the injury site, you have your sutures with you, you know the art of suturing, repair it up, put a drain, come out. But always remember, preventions can be done, it has to be avoided. And this was just the check review of the Rahasya. And thank you and ratings from the first government medical colleges any which accredited in the country, Atal Bihari Vajpayee Government Medical College, Vidisha, Bhopal. And I all invite you for 2 more events. I think most of you there were in Bhopal for the IHS which we have hosted recently. All the press meetings were there. So I invite you once again to 2 mega hernia events which we are conducting in India. One in Delhi in March and the annual ISSNCON once again from the heart of country, Bhopal. Thank you.
Thank you very much.
To me, as we all know, it is one of the basic surgeries we all do during our residencies. And when you're a young surgeon, mainly we start with open appendectomies. Then now people go on and do laparoscopic appendectomies. It has been accepted widely. So you see that appendectomies initially was basically this is a simple surgery, but sometimes it can have dreadful complications and even mortality can be there. So first of all, like for the diagnosis, now we usually do the CT scan and the examination, but CT scan is the gold standard, more specificity and sensitivity. And nowadays there's a new thing coming up like non-operative management, but there's a lot of times that you'll have to go in for surgery, more than 20, 30 times, and in case of complicated appendicitis, maybe 50 times more that you'll have to go in for surgery. So surgery is still the mainstay of the treatment for appendicitis. So the indications for open and laparoscopic appendectomies are similar, and still there's a small mortality there, so you have to be careful while doing the appendectomy. So first, to do a safe appendectomy, you have to train yourself. You have to train yourself to do this. Mainly today morning, Dr. Ishan just said how to create a pneumoperitoneum, and Dr. Manish was talking about preparing your OR. So you have to check the insufflator, the monitor. It's more of a technical job. So you have to get your equipments right, and you have to also train your staff, especially your camera person. And usually most of the cases are done under general anesthesia. So the patient has to be always fit for general anesthesia, and you need to go in for a pneumoperitoneum, so she has to be okay for that. The diagnostic accuracy and wound complications are better over the open procedure. And see, you have the whole abdomen for yourself. You can watch from the liver, the diaphragm up to the pelvis. So any other diagnosis other than appendectomy you can diagnose. If the appendix is subhepatic, you can still go in very easily. Even in case of situs inversus, you can go in and do an appendectomy. Whereas when you're doing an open, you have to make a big laparotomy scar. And the cosmesis obviously is much more better. Now we have HD and 4K monitors and cameras. So these have shown that you can do even complicated appendectomies with very easily. And also energy devices, they help in cases of complicated appendectomies. So you have to standardize the procedure. You have to teach your juniors each and every step how to go about. And that will decrease the complication rate and make it more safe. So we have already seen that it's safe and it's short hospital stay, faster return to work, less pain, and less morbidity. Some of the studies have shown that they have more deep pelvic abscesses, but it has decreased as the experience goes on. So conversion, sometimes, especially the appendectomies are done by the young surgeons here. And they are just starting over. This is one of the first surgeries, cholecystectomies and appendectomies. They are one of the first surgeries that are going on. So sometimes if it's difficult and if you have got no one to help, so conversion is not a failure. So you have, first and foremost, you have to think about the patient safety. The patient has to be safe. So this appendectomy, according to the SAGES guidelines, also is safe for the pediatric patients, for the geriatric patients, and even for the pregnant ladies. So basically you just need the basic equipments. You don't need very fancy equipments to do that, and just even a single chip camera will do initially. So the standard port mainly is in the umbilicus, the 10 mm port, and the other ports can vary according to different needs. And this is the most, this is the port position here depicted. This is the one we use. So which is good triangulation and it's easy. So in appendectomy, first you need to expose the appendix, find the appendix. Sometimes it's difficult to find the appendix. It may be retroperitoneal, retrocecal, or sometimes it may be very difficult. First you need to do a diagnostic laparoscopy and find the appendix. The control of the mesentery and the appendicular artery is the next step. The division of the base. And after that, suction, irrigation, and extraction of the specimen is the next step. So the base can be managed in various ways. You can initially, if you are just a beginner, you can use the window loop, you can ligate it, you can use the suture partial and the Rhodes knot. You can even staple it. So initially the position of the patient is supine and the monitor is on the right side of the patient. And the patient is under general anesthesia. Another thing, whenever you do a laparoscopy case, you should always monitor the ETCO2. That's very important for a safe laparoscopic surgery. So the patient, the surgeon is always standing on the right side, and the assistant is also there. we just talked about pneumoperitoneum. You can do it with an open technique or with a varus needle, whichever you find is comfortable. Both have the similar complications for it. So once you go inside, you do a diagnostic laparoscopy. You see the abdomen, you see what is all there. So in case of laparoscopic appendectomy, you can see right from the diaphragm down to the pelvis, and you can see all the different things. So when you are making a suprapubic port, you have to be always making sure that you don't injure the back bladder. You don't injure the bladder, so you have to always see the bladder, and the patient has to empty the bladder beforehand. You should put a Foley's catheter, so that, and then when there's pus inside, you suck it out. You see different areas. So when there's a collection, you can also send it for culture. So once you do a diagnostic laparoscopy, you see all. If there is any other pathology, there may be some other pathologies, an ovarian cyst, a Meckel's or something. So this you have to see. Then here, when you go, you have to secure the appendicular artery. Here we are going from the base. There's a bipolar for copy, and we are going from the base. And suddenly there is a problem here. You can see the spurt over here. First and foremost, you have to remain calm. And then what to do? You can either pack. Here it's a simple bleed. So just the bipolar forceps did the job. You can also clip it, or sometimes it may be difficult to do that. And when you go on, you go on right up to the base. You have to recognize the base very well. Sometimes you may not go up to the base. You may think this is the base, but you have to reconfirm yourself. This can cause sometimes stump appendicitis. We propagate our juniors to ligate the stump of the appendix, so that when you go into more advanced procedures, so this is a local way, like we use a 16 cannula and a 3-0 nylon to hold up the appendix. It's called a Handmann's technique, so that we don't need an extra port to ligate the base of the appendix. So here we are just using this 3-0 nylon to hold the appendix up. Then another important part is to control the base of the appendix. What do you do? So you can ligate the base with just a 2-0 silk suture or a Viking suture. Another thing is you can either put a reader's knot or an endo loop inside to manage the base. And you can even staple it with an endo stapler. So the most important thing is when there is perforation or the base is very unhealthy, what do you do? So it becomes difficult for you in those situations. You can either transfix it when there's a perforation near to the base so that it does not slip, or you can even take a purse string suture. So the management of the base is also very much important, so that the patient does not have a fecal fistula later on. But when there is a perforation near the base, we have to explain to the patient party that there may be some other complications there. So then after ligating, you can put a single, but when the appendix is very much swollen, you have to ligate twice. Okay, ligate twice. So you have to put another ligature proximally also, so that there is little contamination. So once the base is tackled, then it is the removal of the appendix that's important. So if it's just a small, it's early appendicitis, then you can just put the appendix inside the 10 mm trocar and remove the trocar. So that will prevent the infection. But once, if the appendix is very swollen, if it's gangrenous, there's lots of infection and pus, you always have to use a bag. It can be a bag for gloves, or a plastic, or another plastic bag. So all these can be used to remove the specimen. So after doing all this, another important thing is suction and irrigation. So SAGE's recent guidelines, 2023 guidelines, have said that even if you just do irrigation, that's enough. Even if you don't do suctioning, the complications rates are similar. So you can, but I prefer to do suction irrigation if there's a lot of pus there. And if there's a lot of pus, and if you are if you are confused, then you need to put a drain. So drain is also like, according to the recent guidelines, if you put a drain, there is always a chance of second operation is higher. So this is cutting out the appendix and then removing it in a specimen bag. So suction irrigation is done. So you can really do the suction irrigation all over the abdomen when you are doing a laparoscopic surgery. If you are doing it open, it's more difficult. So in this case, before we control the mesentery from the base, here we are just using a bipolar forceps and we are going close to the appendix to control the mesentery. The vessels are small, so there's less chances of bleeding. So you just use a normal bipolar forceps and scissors, or you can also use the bipolar scissors for controlling the base. And in this case, we tie a reader's knot. We use an inner loop to secure the base. So in case of complicated appendicitis, when there is a lump or a perforation and adhesions, it's very difficult sometimes to go and even visualize the appendix. So in this case, when there is an early lump, just a suction and a grasper you can dissect the appendix very easily in doing that. But when there is a lot of adhesions, you can see that the adhesions are very harsh. So sometimes you'll have to go in very slowly with a suction, and sometimes in these cases you have to think. If you are not sure that you can go in laparoscopically, you can always call your seniors or call for help. That's better than rather perforating the bowel. So whenever you are using energy devices close to the base, you have to be very careful that you do not perforate the bowel. So in this case, you need to call for help, and doing an open surgery is not a failure. So you have to always go in for that. When there is a perforation near the base, you have to ligate using the endo loop, or you can transfix it. So here we are using the omentum and to cover the base of the appendix. So I think with all this, you can perform a better and a safer laparoscopic appendectomy. Thank you very much.
Thank you, Dr.
So that we can learn as soon as we can learn.
Obviously, we had complications. Every surgeon, when you operate, you have complications. If you do not have any complications, either you are not operating or you are telling a lie. So we had complications. We had intra-abdominal abscesses when you are doing complicated appendicitis. Sometimes even perforation of the bowel is there. Bleeding is there. So once when I was a resident, in Army Hospital, I was in the first year residency. I was doing an appendectomy. Maybe that time we did 2-3 appendectomies. And my senior sir, Professor Dr. B.K. Hamad, was there with me. And then suddenly I got a call at 5 o'clock in the morning. And then they said that, okay, the patient's blood pressure is down. The patient is down. So I said, give him some fluid. We already gave him some fluid. Then I was there. And I said, okay, I went and immediately looked at the patient. The patient was very pale. I said, okay, we need to reopen this case. I could certainly call my senior. And then she said that, okay, just going through a midline incision, you start and I'll be coming over. And then I was so afraid. I was a first year resident and I was so afraid that my senior would scold me. And Dr. Hamad, Professor Hamad, he came and said that, okay, Dr. Romeo, congratulations. I was surprised. Why? Then he told me that now you have become a surgeon, you have made a complication, you have recognized it in time, and you have managed it. So that is a quality of the surgeon. I think you should also share your complications.
Sir, has a question. Can I?
Next presentation, I'm Professor Majid from Lahore. Just a little food for thought. About 30 years ago, I described extracorporeal laparoscopic assisted appendicectomy. You know, what we do is you go through the umbilicus with a 3 mm or 5 mm port, see the appendix. You can do in most of the cases. just identify the appendix, deflate the abdomen, feed it into the 10 mm port in right iliac fossa, and bring it out. And it just takes one stitch and one ligature, and you can do the appendicectomy in most of the cases. In complicated cases, yes, I think you can always go and make another third port and do the appendicectomy. So it's just a food for thought, for young laparoscopic surgeons, that you can do it with. And the only scar that a patient has is a 10 mm scar, and in children even 5 mm scar in the right iliac fossa. Thank you.
Thank you very much.
Thank you very much.
Okay. Okay.
The drain, after doing this, as you mentioned, the drain has the more complications, the drain has the more chances of the redo surgery. So what is the reason behind the redo surgery or the complication by keeping the drain in after doing the suctioning and drilling?
So usually I always put a drain. If I am confused, if there is a perforation at the base, if the cecum is unhealthy, I usually do put a drain. But the recent literature that has shown is like to put a drain or not, the complications are the same. That the SAGES 2023 guidelines have shown that. But I usually do it. I am a more conservative surgeon, I suppose.
Thank you. Thank you.
And indeed, an honor and a great pleasure to be here from India. I bring greetings from India and abdominal wall reconstruction surgeons community. And I thank Dr. Ghimire, Dr. Sunil, and all the organizers of this excellent conference. So the topic that has been given to me is safe hernia surgery. And when I did a Google search, the surgeons who made surgery safe, two names have come up: Sir Joseph Lister and Dr. Atul Gawande. And we all know Joseph Lister was the person who made infection control possible. And what does this safe surgery in hernia entail really? So it will entail no complications or no morbidity, or both. But obviously, this is a distant dream yet. So safety starts with the surgeon, with patient selection, with procedure selection, setup, technique, post-operative care, and strict asepsis. So patient fitness is obvious. I will not go into great details in this slide. But age, if we look at this great paper, which was an 11-year Swedish nationwide cohort study, patients aged 80 years and older had 2.5 times higher risk for a complication leading to reoperation and a 12-fold higher mortality risk. So age is a dominant mortality risk factor. So obviously when it comes to any hernia surgery, we would not want to risk this patient with a general anesthesia and a complicated procedure, especially if a less risky procedure is available. And obviously, if the patient is unfit, then a local or regional anesthesia will be called for. Pre-operative optimization of comorbidities is very important, but that's entirely a different talk. So, as the reference to Joseph Lister, infection is the bane of hernia surgery, and this is what we often get to see. When the patient is operated for a beautiful laparoscopic surgery, a TAPP has been done 6 months back, and the patient has come with persistent fever and swelling for last 6 months, and you can see that now there's a lot of muck, there's collection inside, and there is a mesh infection. So hernia surgery, which was a daycare surgery, has ended up in a devastating complication where this patient had not just bacterial infection, but this was mycobacterium other than tuberculosis, the MOTT. So commonly associated with the water that we use for sterilization of our instruments. So MOTT will again take 6 months of treatment and multiple debridements. So the strategies for prevention of mesh infection, we all know that prophylactic antibiotics are necessary. All instruments have to be absolutely sterile, including the cables. We have to change gloves before handling the mesh. Mesh should be exposed for a minimum time, and no contact of the mesh should come with skin. It should be directly introduced inside the abdomen. No other clean or contaminated procedure should be done along with hernia repair. It's a common fashion to do gallbladder surgeries with hernia. It may not be wise to do that. And fixation device, we use 1 or 2 tackers and tend to reuse it. It's a strict no-no. Mesh should obviously be a large pore size. So when it comes to technique, every part of technique can lead to some morbidity like access, adhesive lysis, closure of the defect. The posterior rectus sheath closure, mesh size, even the port closure can lead to a complication. So here's a very simple TP surgery done, mesh, 3D mesh nicely spread there, and probably the procedure was over. But then that was not to be. This was a bilateral hernia repair. But as we were withdrawing the ports, we saw something unusual. We had introduced this mesh and the patient had just bucked. So we did a diagnostic laparoscopy, and what we found was a large peritoneal tear. Now, in an inguinal hernia repair, this kind of a peritoneal tear is in a very inconvenient position. It is very high, close to the ports. So now we'll have to put another 2 ports and do a transperitoneal repair of this defect. But obviously, if we leave this defect alone, this patient can land up with intestinal obstruction. So safety is absolutely necessary, even if that means 5 or 6 ports. Again, a simple ventral tap, a preperitoneal repair being done. The dissection is progressing very nicely. But obviously, in a young patient, the peritoneum can be thin, and we can already see that the initial dissection was absolutely faultless, but here the peritoneum is so thin that we can see these holes coming there. And obviously, every surgeon would want to try and suture it, but may not be possible in every patient. You can see that it's such a paper-thin peritoneum. It's not going to come together. Now we are committed. The patient is not going to afford a dual mesh and a tacker. So we have to shield this polypropylene mesh with an absorbable mesh. So a vicryl mesh is a great saving device. So all of us must have these kind of meshes which are not very costly in our theatre, or use some device, or then convert the procedure to some other procedure which is safer for the patient. Adhesive lysis can change the outcome of a surgery, because enterotomy, the bowel enterotomy, if the diagnosis happens in the post-operative period, is a grave event with morbidity as well as mortality. And the mortality diagnosed in the post-operative period is 7 to 40% in one of the largest series in India, and the mortality rate is 3.6. So if we have to do adhesive lysis, we tend to use high energy, absolutely high-tech devices like this, but this device can be pretty dangerous because there's a warm blade next to it. Now, we are trying to take care that this warm blade is not in communication or in contact with the intestines, and we are trying to keep it away from the bowel. But obviously, this is not so safe. If we look at this, again, a hernia surgery, the surgeon is trying to do safe adhesive lysis, now using scissors. This is a recommendation that no energy source should be used. But even any instrument can lead to a disaster. Now here, again, the bowel is he's trying to separate the bowel, and slowly a few snippets are being taken, thinking that it is safe, obviously. But there is still bowel there, and the bowel is twisted. So we are still not sure whether we are safe here or not. So this kind of scenario, maybe the camera is an odd port, the camera angle is odd, and we just have 2 instruments, nothing more to retract there. And this division may lead to an enterotomy. So we have to be very, very careful in doing this adhesive lysis, because what is going to be a clean repair when the patient walking home on the 2nd day might land up this patient with a grave morbidity, because this intestine is twisted and still there is bowel there, and one never knows if we progress further and we are not safe, this patient can have an enterotomy. So strategies for prevention, obviously energy source should not be used, checking insulation of instrument before the start, thorough examination of our bowel after the adhesive lysis. You can use an open or hydrate technique, we do that commonly. So instruments do not make a surgeon safe. It is a safe surgeon who makes it safe. Like what we see here. This is a robotic hernia repair is being done. But now there's bleeding here, and this bleeding was from the iliac vein. And this patient needed a conversion, and a vascular surgeon had to be called in. So robotic surgery does not mean that hernia surgery is going to be safe. It is a surgeon. Another very simple case where the mesh was very nicely there. but the resident thought that maybe this fold needs a little fixation. So a suture is being taken there. You can see the inexperience of the resident. Okay, but this suture now is starting to bleed. So obviously the solution is going to be more sutures. So we put more sutures, trying to seal that. It's just a simple inferior epigastric. So nothing life-threatening here, but the bleeding continues and ultimately it stops. But when the patient returns to the post-operative ward, the moment he's awake, he's complaining of severe pain. Next 36 hours, everything including local blocks were tried. This pain did not go, so I had to take him on the next day, remove that suture, and the patient went home on the third day, almost pain-free. So ETEP-RS is the new kid on the block, and Ingenuity neurovascular bundles which supply the rectus muscle. Obviously, this is the first step of a retrorectus dissection, and sometimes this neurovascular bundles can be injured. Sometimes the dissection is progressing very nicely. The surgeon is confident that he is going into the right plane, and a TAR is being done here, but we can already see one neurovascular bundle divided. So this patient is going to have a kind of a bulge which will not be curable by any hernia repair. Again, we can see that this CT scan is showing disruption of the linea alba here. And this is a large disruption after an ETEP reef stopper repair. And this is because when we cross over from one side to the other, this is the linea alba. And we should be going actually horizontally like this. But if our direction changes in an upward direction, because this is the linea alba, then we are going to injure it, and then we will start seeing the yellow fat, and the result will be a large hernia after an ETEP reef stopper, and this will again need a bigger surgery than this. Even more devastating can be these kind of Mickey Mouse hernias where the linea semilunaris has been injured. So here you can see that there is a hernia on the left side, right side there is a hernia on the left side. So this is a linea semilunaris injury, and this is a devastating injury because this involves even the neurovascular bundles. So the abdominal wall, this patient becomes a cripple, and again it's just because the surgeon does not realize that his direction is taking him into another plane and not the proper plane. So safety is basically absolutely important, otherwise this patient will have a crippled life. Early identification of post-operative complication, and for that we need awareness of procedure-specific complications. We need a low index of suspicion, post-discharge instructions for emergency signs, and low threshold for investigations. Now if you look at this ETEP reef stopper repair done for a simple hernia, not a very big defect, and the patient goes home on the second day, obviously the repair looks robust. There's an associated inguinal hernia also. So once this repair is done, then the patient at his home starts getting distension, vomiting, and lands up in the hospital on the fourth post-op day because the patient was conserved there for 2 days again. And now we can see that there is a devastating complication of the posterior rectus sheath rupture where all the bowel has gone inside. Luckily, this patient escaped having strangulation or gangrene of the bowel. You can see the devastation there, and this is now going to need a costly repair because probably a dual mesh will be needed, and just half a minute more, and one can see that the mesh is also now looking very shaggy. So the setup, we all know that high volume centers reduce the complication rates, and post-operative care, we have to take care of DVT prophylaxis, we have to be vigilant for complications, wound care, early ambulation. So my friends, safe surgeon means training, a mentor is essential, a surgeon has to follow and be truthful to the principles, has to have proper systems, continuing medical education is very important, teamwork is obviously the way forward, and community support is absolutely essential. So I take this opportunity to invite you to 2 great conferences that Abdominal Wall Reconstruction Surgeons Community is going to have. One is a summit of Young Turks, which is happening in Goa. And in 2025, we have the Deep Impact, which is going to be a high impact conference, an international conference. And I invite you to join our community to have all the support and sharing and learning of knowledge that Abdominal Wall Reconstruction Surgeons community is committed to. Thank you.
Thank you, Professor Sundar. Through quickly a couple of videos here. First, a laparoscopic abdominal peritoneal resection for a distal rectal cancer, post-chemo radiation, and then we'll go through a laparoscopic right colectomy. Firstly, I'd like to apologize. These videos are a little old. First tip I would say is please back up your backups because my hard drive got corrupted and I lost all of my recent videos. But so for an APR, I'm not going to go through the port placement and everything else. That's already been dealt with. We usually go in a medial to lateral technique at the base of the sigmoid mesocolon, taking the peritoneum initially medially and entering this plane. So as far as safety is concerned, identify the anatomy, know the anatomy, make sure that you're in the right plane, and then take small bites. Whether you're doing blunt dissection, sharp dissection, take small bites, make sure you know what you're dividing. Like one of my mentors always told me, it's like tailoring. Measure twice, cut once, and not the other way around. And then you get into this plane under the superior rectal artery, moving proximally to the base of the superior rectal artery and the inferior mesenteric artery here. And then do a little bit of a medial to lateral dissection under the sigmoid mesocolon, proceeding laterally. I always identify the ureter before I divide the artery. As you can see, the ureter is moving over there because right at the base of the IMA is where the ureter is actually extremely close to the artery at times, particularly after radiation and after and malignancies where there's a lot of desmoplastic reaction. And then you can go ahead and divide the artery with a method of your choosing. Over here, it was a pretty small artery, so we felt comfortable taking it with the ligature device. I usually ligate on both sides and then divide in the middle. Or you can clip it, you can envelope it, you can use a stapler. Really, it's completely up to you. Thereafter, furthermore, medial to lateral dissection, going laterally as well as proceeding distally. Here, over the sacral promontory, into the presacral space, into your avascular plane there, to proceed distally for your rectal dissection. We're taking some of the lateral attachments here on the right side, moving distally into the pelvis, into the cul-de-sac. Posteriorly, you see we've already dissected some of the rectum out right there to do a total mesorectal excision. Taking some of the lateral ligaments there with the ligature again. And again, dissecting posteriorly in the presacral space. Again, the thing is, make sure your exposure is right, make sure you know exactly what you're dividing. You don't want to go too far posterior in the interests of trying to get a radical resection, because if we get into the presacral venous plexus, then your day can go from a good day to a very, very, very bad day in a matter of seconds. Then once we're done with our medial dissection, here we're proceeding laterally, taking out some of the, once we've done the posterior dissection, going laterally to take off the attachments of the sigmoid colon here from the abdominal wall on the line of Todt, and then proceeding distally into the pelvis. Now, you can take the lateral attachments before if you want to. That's completely your choice, and I will certainly do that at times. And as we proceed distally into the pelvis, again, staying away from the pelvic side wall. You don't want to injure the internal iliac artery. You do not want to injure the ureter as it curves around to go into the bladder. In this case, this is a female. The uterus was not very bulky, so we just elected to retract it with a grasper, but you can certainly retract it away. For a bulky uterus, I'll often put in a sling of a suture from the suprapubic area under the uterus and lift it up to the anterior abdominal wall so that it's out of the way for our dissection. And as we, again, go into the cul-de-sac and approach our anterior dissection, you don't want to injure the vagina, particularly in cases where they've already had a hysterectomy before. You can get into that vaginal vault, so I tend to put in a sponge stick into the vagina just to make sure that I can feel it, see it by moving it around, and make sure that I'm not injuring it. Here we're just taking the remaining lateral attachments on the left side and then meeting our anterior plane of dissection. And then proceeding distally again to complete our dissection. Now, after this pelvic dissection is done, we just usually check for redundancy of the sigmoid colon to make sure that we can do a nice tension-free colostomy. And then we go ahead and divide the mesocolon just proximal to the inferior mesenteric artery up to the bowel wall. Thereafter, I usually place a 10 flat JB drain into the presacral space, and then exteriorize the bowel from the colostomy site. We usually use an open stapler to divide our bowel in the interest of cost, because laparoscopic staplers are quite expensive over here. And then after we divide this, I will reduce the distal end back into the abdominal cavity, go back in with the laparoscope, take a look at the colostomy to make sure that it's not twisted, and then put in the proximal part of our specimen into the presacral space behind the rectum. And then also, I try to stuff in some momentum into that presacral space, which we will use to fill up our dead space in the pelvis after we resect our specimen. And then that completes the abdominal part of our procedure. Usually, we will then close all our incisions, mature the colostomy, and then flip the patient into a prone jackknife position for the perineal portion of the procedure. Now, quickly going to laparoscopic right colectomy here. So again, quick abdominal survey, putting in course on the direct visualization, which has already been covered by my previous presenters. Initially, always identify where the tumor is. In this case, it was a villus adenoma in the ascending colon. And I always take a look at how redundant the bowel is to get an idea of how much we need to mobilize. So we, again, do this as well, usually in a medial to lateral fashion, lifting up the ileocecal junction with a grasper, usually tense up the ileocolic pedicle pretty nicely. And then we go ahead and start dissecting at the base of the ileocolic pedicle. In this case, we're using a harmonic scalpel and skeletonizing the vessel. And as with any vessel, the better you skeletonize it, the better you can get a seal on it, be it with a clip, be it with a vessel sealing device of any kind. And then as we're doing this, it's always very important to know exactly where the duodenum is, because at the base of the ileocolic is where the duodenum is quite close. So we do a little bit of medial to lateral dissection, identify the duodenum before we actually divide the vessel. Continuing to skeletonize over here. Then we elected to put in clips proximally and distally, following which we divided this ileocolic pedicle with the harmonic scalpel. Thereafter, we continue our medial to lateral dissection, both superiorly and laterally, going towards the hepatic flexure, mobilizing the transverse colon and the ascending colon completely. The proximal transverse colon, at least I should say. As you can see over here, the duodenum is on the right side, and it's safe. And again, in theory, this should be an avascular plane, just going across. We can do a little bit of blunt dissection. You can use your suction, you can use a grasper. Honestly, instrument is your choice. Thereafter, we direct our attention laterally to the lateral peritoneal attachments, mobilizing the right colon from the abdominal wall and from the retroperitoneum and from the gyrotous fascia, and going again more distally along the ascending colon towards the hepatic flexure. And once you've done most of your dissection from the medial aspect, the lateral part of our dissection usually is fairly easy, and you don't really have to do too much. Then we direct our attention up above the transverse colon into to get into the lesser sac. And again, over here, please pay attention to the anatomy. Make sure you get through the momentum and get through into the lesser sac. But it is actually quite easy at times, particularly when there's adhesions, to think you're dividing, and just getting to the lesser sac, but you're actually dividing the mesocolon, and then all of a sudden you realize that maybe you have not done an oncologic resection, or maybe now you have to resect more bowel than you previously planned to resect. So, again, measure twice, cut once. And going towards the hepatic flexure here. And once your mobilization is complete, I always check to make sure that the cecum and the terminal ileum can actually reach the left upper quadrant to make sure there's a tension-free anastomosis. We typically do an extracorporeal anastomosis, again, in the interest of cost. And then after the anastomosis is done, I always reduce the bowel back into the abdominal cavity. As you can see, that's the anastomosis. And I check the orientation. When you've really mobilized the bowel well and you've exteriorized it through a small 3 or 4 centimeter incision and done the anastomosis, it's actually, believe it or not, quite easy to rotate the bowel 360, and then all of a sudden this patient is going to end up with a bowel obstruction and potentially an anastomotic leak post-op. So proximally and distally, always a good idea to check and make sure your bowel is laying tension-free and in the correct orientation before you actually terminate the case. And then I always put a little bit of momentum over the bowel. I typically do not use drains for these cases, and then that concludes the surgery. So to sum up, really, I mean, as long as you follow the basic principles of laparoscopic surgery, or honestly any surgery, you can do these cases safely, particularly when you're starting out. Do however much of the case you feel you're comfortable doing laparoscopically, and failure to, it is not a failure to convert to open. What is a failure is us not doing the right thing for the patient. So whatever you're comfortable doing, do it with that approach, and the more you do, the more comfortable you'll get. And obviously, always reach out to your mentors if you need to. Thank you.
Thank you very much. Any questions?
Speaking on difficult laparoscopic cholecystectomy, but I'll be focusing more on subtotal cholecystectomy. So this is only one part. So because of the constraint of time, I'll just be talking on laparoscopic subtotal cholecystectomy, a bailout procedure for difficult gallbladders. So I have no conflict of interest to declare. So I'll be giving a brief overview with types of laparoscopic subtotal cholecystectomy, describe the operative procedure, and also share briefly about how we have managed these cases. So the laparoscopic subtotal cholecystectomy is basically removal of the portion of the gallbladder when the structures in the calyx cannot be safely dissected, or if this dissection is deemed dangerous to dissect. And it was first reported by Madding et al. In 1955. So the common indications are cholecystitis, whether it be acute or chronic, empyema of the gallbladder, perforated gallbladders, Mersey syndrome, and also in cases where there is portal hypertension, where the dissection into the hilum may be dangerous. So this matched national analysis of cases of total laparoscopic cholecystectomy and laparoscopic subtotal cholecystectomy was done in the US. So you can see that the number of total laparoscopic cholecystectomy was more than 130,000, and of which laparoscopic subtotal cholecystectomy was 487. Here we can see that the proportion of patients of male gender was higher in the laparoscopic subtotal group. Though the proportion of patients in both the total and the laparoscopic subtotal group were the less than 40 years of age was common in both the groups, the tendency there here was that the patients above the age of 60 years was proportionately higher in the laparoscopic subtotal group. So what we need to know is that the male patients and the elderly patients are more likely to land up with laparoscopic subtotal cholecystectomy. With regards to complications and outcomes, like the mortality was higher in the laparoscopic subtotal group. The readmission was also higher in the laparoscopic subtotal group with longer hospital stay, and the cost was also nearly 50% more in the patients who had undergone laparoscopic subtotal cholecystectomy. So this is Steven Strasberg, advocate of safe cholecystectomy. You know him by the Strasbourg classification of bile duct injuries. He had classified the subtotal cholecystectomy into fenestrating and reconstituting types. So what is fenestrating type? Well, the orifice of the cystic duct, it is just sutured and it is obliterated, and either there are adhesions posteriorly, if the posterior gallbladder wall is adherent, then you leave it behind. If not, then you can remove it. So this is how fenestrating variant is. And in the reconstituting variant, the stump of the gallbladder is sutured. So the cystic duct orifice is not closed. And even in this variant, like you can either leave behind completely or partially the posterior gallbladder wall, and you can remove it in a whole. So these two variants were analyzed, and what it showed was that the conversion rate, the complications like retained stones, subhepatic and subphrenic collections, wound infection, 30-day mortality, as well as need for post-operative ERCP for bile leaks and reoperation, all were higher for the fenestrating group. Again, this subtotal meta-analysis on subtotal cholecystectomy for difficult gallbladders, where initially 750 articles was selected and scrutinized, and in the end only 30 studies were selected for the meta-analysis. So basically this study had different surgical techniques that were compared. So one of them was comparing whether you leave behind or remove the posterior wall, where you could see that the bile leak was higher in the cases where the posterior wall was left intact. And also there were studies where even after the removal of the gallbladder, the remnant stump was just left open, like it was not closed at all. So analyzing the data here, it showed that obviously, for obvious reasons, the subhepatic collection and bile leak, everything was higher in the non-closure group. And interestingly, you can see that out of 100 patients who had undergone this procedure, 42 patients developed bile leak. So in fact, 60 patients did not develop bile leak, because at times the gallbladders are afunctional and there is no bile that is leaking out. And even those who required had bile leaks, only 15 of them out of the 42 required ERCP. So even there is a chance that spontaneously, maybe a 2/3 of these cases have the spontaneous closures. And with regards to open and laparoscopic, well, the bile leak rate was higher in the laparoscopic group, but other parameters like retained stones, post-operative ERCP, wound infection, and reoperation again was higher in the open group. So with regards to the dreaded complication we all fear of when we do cholecystectomy, is the bile duct injuries. So you can see that only 1 out of 1,000 patients in the 1,011 patients who had non-removal of the posterior wall, and 1 out of another 1,061 patients who had closure of the cystic duct, only 1 patient developed bile duct injury. So it was deemed safe to perform laparoscopic subtotal cholecystectomy. So I'll just be running through the videos. So we can see that once the cavity is not identifiable, then you just need to open up somewhere safely, maybe a centimeter higher on the gallbladder. So in this case, this was an empyema of the gallbladder. Once this was opened, there was a gush of pus, and following which there was also a large stone that was there in the heartland. So this was a type 1 merism. So once the stone was removed, we could see that the stump was there and it was thoroughly irrigated. So after the irrigation, we need to irrigate it properly just to identify small stones. If there are small stones, sometimes the stones may be present. And following which, the remnant mucosa of the cystic duct, the remnant gallbladder is coagulated, and the suturing is bigger. So in the fenestrating variant, as we said, we just go in and try to occlude the orifice of the cystic duct. So this is performed. We usually tend to use 3-0 polyglactin sutures. So sometimes if the gallbladder is very much thickened, sometimes you might even as well use 2-0 sutures as well. So these sutures are used, and these sutures in fact can be used in a purslane fashion as it was shown by Strasberg, or we can use these running sutures to occlude the lumen from posterior to anterior. So following this, then the sutures are ligated, the ligation is done. So very important thing is we usually do not remove the remnant gallbladder before doing this. So if you have the remnant gallbladder, it is a very good traction for you to have, and then that makes this suturing very much easy. So this is more or less the completion of the suturing and the tying, and it's always necessary that we check whether there is bile leak or not after this, because you might need to have some reinforcing sutures that are required. Following this, so in this patient, the posterior wall of the gallbladder was removed. So the removal of the posterior gallbladder wall, usually the gallbladder wall is very much thickened and it is very vascular. So a very important armamentarium in a surgeon's instrument is this bipolar. So all of us, maybe we might not be having all these sophisticated harmonics or the ligatures. Bipolar is a good enough tool to tackle these cases. This is not only handy in subtotal cholecystectomy, it is also handy when you have acute cholecystitis, when the gallbladder is very vascular. So the bipolar can be used, and it is a very fantastic tool. And we put in a drain, and the gallbladder as well as the stones are retrieved through the in a specimen bank. So this is a reconstituting variant where you can see that there is again a very large stone, and you can see the posterior sectoral ducts that are entering quite high up. So it is very dangerous just to go very much down. And so we open the gallbladder up. I'm not showing that part because it is a replication. So the suturing, how it is done is that in contrast to the fenestrating variant, we have the stump of the gallbladder that is sutured. So the two lips of the remnant gallbladder are sutured. So very important aspect in this suturing is that we need to know where we are going to give the incision. So if you are going very much down, you might as well injure the CVD and the posterior sectoral duct. And even suturing also, the sutures should not go very deep below, so as not to injure these structures. So once this is completed, the suturing is completed, then we do the ligation. So as I said, even in this variant, like sometimes once we complete this suturing, there may be some leakage of bile. So in that case, you might need to take additional sutures just to reinforce. And if you have good laparoscopic suturing skills, then this procedure in fact is not a very difficult procedure. It is a very simple procedure, and you in fact need not convert it to open surgery. So this is the suturing part that is almost complete. So it is very important again to do a thorough irrigation. You can see that there is a lot of bile period there. So you need to irrigate very properly, and also to see whether there is any leakage or not. So the remaining part, just in the subtotal variant, as I said, you may leave behind the gallbladder or you may remove it as a whole. In this patient, because there was a lot of adhesions posteriorly, we just left the posterior wall of the gallbladder. So this is also a very important message in the sense it is not only for subtotal cholecystectomy. When the gallbladder is very inflamed and you feel that you are not able to remove it, I think that you should not go in and try to remove everything. So in this condition, you might go in and cause torrential bleeding as well. So here we are just leaving behind the posterior wall of the gallbladder, and then you can then coagulate the posterior wall. So just to share our experience of doing subtotal cholecystectomy, these 2 years that we have operated, so the patient's mean age was 55, and even in our study there was a male preponderance, and around a quarter of the patients required preoperative VRCP for cholecystectomy, and we had more of fenestrating type of cholecystectomy. Operative time was more or less just over 2 hours, and the conversion to open was in 0 patients, and there were various operative findings were there. And the bile leak was seen in 3 patients, out of which 1 patient had major bile leak which required ERCP, and there was residual stone in 1 patient and bile duct injury in 1 patient. So this was in a single patient. This is 1 patient who was just operated recently. So this was a patient who had chronic cholecystitis, who was operated. We did a subtotal cholecystectomy. But unfortunately, the patient came back with the symptoms. After 2 months, we did a MRCP. We found that after ultrasound, there were some stones in the remnant cystic duct stump, they said, and then we did a MRCP, and where you could see that there is this area where there are stones, and then we went ahead and did a completion cholecystectomy. So my thought was that since this was a remnant, I didn't want to leave behind anything there, so probably I went too far in. So there was not a obvious injury as such, but you can see the date. This was in January 2023, and in June, after 6 months, the patient presented. So it was not an immediate injury. What I presumed was it was a vascular injury, and that too, we also did a CT angiogram, which did not show that there was any major vascular injury, but I think some portion of the gallbladder means the common bile duct might have gone ischemic, and it was a very difficult injury in the sense that you can see that there is dissociation of the bile ducts as well. So it took a lot of time. We had to go in and do a hepatic angiostomy. You can see all the 3 the orifices, the left duct, the right anterior and the right posterior sectoral ducts had to be separately identified and a hepatic angiostomy done. And following hepatic angiostomy, after 6 weeks before the PDBD removal, we could see all the ducts, the right posterior, the right anterior and the left duct. So we can sometimes land up with all these problems. So to conclude, I would say that laparoscopic subtotal cholecystectomy is a safe bailout procedure in a situation where you have difficulty in achieving the critical view of safety, and it is also a surgery with high complication, conversion to open, and also increased post-operative morbidity compared to the open variant. And reconstituting laparoscopic cholecystectomy is the preferred technique based on all the outcomes as shown on the data. Thank you so much.
Thank you very much. Wonderful presentation. And I think the residents should learn these options also. There's some questions here.
Cholecystectomy is basically a bailout when you actually can't achieve critical view of safety, not even in simple, but in difficult cases as well.
Yes, definitely.
Doing a difficult cholecystectomy, we have been performing difficult cholecystectomy. I guess majority of surgeons are performing difficult cholecystectomy and achieving critical view of safety. Difficult cholecystectomy and doing subtotal fenestrating and reconstituting has its own complications furthermore.
Yes.
It's just a bailout or a rescue procedure in case you are not able to do.
Yes, when you are not able to complete it.
Yeah. So subtotal, if you do a fenestrating, so there is a chances that the patient's stay is extended,
yes,
and you have a more period of bile leak.
Yes.
Because you have just sutured in the mucosa, yes, and that takes some time, and there's a drain is a must.
Yeah.
Second, in a reconstituting type, there are high risk of chances of a recurrent stone formations, yes, and again a gallbladder, and a second procedure again.
Yeah.
So in difficult situations, what we are discussing here in a safe difficult situation, how we tackle. If it could be empyema, it could be probably the video you showed was an excellent, but I would have rather done, if you had removed the stone, I would have done a complete cholecystectomy rather than doing a subtotal cholecystectomy.
Yeah.
And after that you are using a hook and you are removing the gallbladder.
Yeah.
I guess you can still remove the posterior wall also the way this gallbladder was. Yes. It is just it depends upon how you relieving the posterior wall in such a such a gallbladder, and probably more dissection is needed. That is why there is so much of talks and discussions. And in regarding
what is the harm in leaving? So if there is any data to suppose that if you leave the posterior wall of the gallbladder, that causes problems.
No, that doesn't mean that every empyema and every
no, I'm not talking about every case.
Gallbladder we have to leave the posterior wall.
See, I showed you 2 cases where in one we had removed it, in one we had. So it is the discretion of the surgeon in the sense that we have had instances where we went posteriorly and we have had torrential bleeding where we had to convert. So it is again it's a two-edged sword.
It's a two-edged sword, but it is when we, when in a forum, when we teaching means, when we give a message, all difficult cholecystectomy should not be converted to subtotal. That is the message.
No.
When there is a dissection and adequate dissection, we can completely do cholecystectomy in majority of difficult cases. I would be showing you in my presentation that how we achieve in Mirzi type 1, how in empymas, CVS. So that doesn't mean, yes, to some extent when there is a need, it's a bailout. It's a bailout. Or you do open or you do subtotal. That's a, you can't even specify difficult to only subtotal.
I've not specified that all the difficult cholecystectomy have to, because like if you see like out of maybe this is maybe around 2,000 cases of gallbladder surgery, only 36 have been done with subtotal. So my message is that it's not all cases that would require subtotal cholecystectomy. It is only in the case that you absolutely cannot identify the callots, where in those cases only I would contemplate subtotal cholecystectomy.
I would rather modify this statement, not identify callots. I would say the callots, we have gone beyond the callots, now it's the hepatocystic triangle. So if you stay the callots, still there are more chances. So unless it's a frozen, then
I
you
think
can
we
shift to subtotal.
Both are saying a similar thing, so I think that we should stop here.
So I've also supported.
I've been given a topic of a video on a laparoscopic nephrectomy. So we started with open surgery, and since the last 10 years we have we are doing more and more laparoscopic surgery, and these days most of the renal surgeries are done laparoscopically in most of the centers in Nepal. And then because we already have so many trained robotic surgeons in the country, we are hoping that we'll be having a robotic surgery in the country very soon. So there are certain indications of nephrectomy. So most commonly we perform nephrectomy for malignancy and non-functioning kidneys. And these days in our centers also we are also doing donor nephrectomies. So these are some of the indications of partial nephrectomy. I'm not going in detail. So this is the beginning of the partial radical nephrectomy. So we create a pneumoperitoneum with the help of Barrett's needle, and conveniently we put ports. And start with mobilization of the colon. On the right side, we normally use a harmonic scalpel. Sometimes, if the harmonic scalpel is not available, we can also use a hook to mobilize the colon. And this is very important because, like, sometimes if you see there, sometimes you can go into the fat of the abdominal wall. So you just keep on mobilizing. This is mobilization of the duodenum. So this mobilization should be done very slowly and then very cautiously, so that there is no bleeding, and the space inside the area is around the kidney becomes very clear, so that the hilum dissection becomes easier. So this is I've separated the ureter from the gonadal vessels. So on the right side, actually, you can just lift the ureter away from the gonadal vein, whereas on the left side, you can take both ureter and gonadal vein together. So this way you can actually prevent attraction of the gonadal vein in the IBC. Otherwise, if you take both the structures, there's a chance that IBC may be avulsed or they may be bleeding from the IBC. So you keep on mobilizing, then you lift the road wall of the kidney, and then slowly you lift. So then you see the hilum. And luckily in this case, the renal artery is very easily visible, and then it's easy to dissect. So you slowly dissect the renal artery, and then you do it few times, so that your hemoclip goes very easily. So normally I tend to keep few hemoclips towards the aorta side and only one clip towards the kidney side. So once you divide the renal artery, normally these days I just keep one clip and then go to the renal vein. So after dividing the renal artery, you go to the renal vein and slowly dissect the renal vein and then clip. So once the renal artery is clamped, the renal vein is so collapsed and very easy to dissect. So this hilum dissection is the most important the part of the nephrectomy, because even a small tear in one of the arteries can be a catastrophic and even a life-threatening. So you just slowly do your hilum dissection, divide the renal vein, and then slowly so this was the easier nephrectomy, but you can come across difficult ones. Sometimes your renal artery is absolutely behind the renal vein. So in that case, you can actually put this vascular tape and then retract the vein, and you can dissect the artery so that the artery can be visualized easily. The other case on the right side, there are multiple vessels going to the kidney. So you have to individually divide each of the vessels. So these are the different cases, some of the difficult cases that we encounter during our nephrectomy cases. So after dividing the tackling the hilum, you just divide the ureter and then slowly. So if you go to a right plane, you see there's no vessels and the kidney is peeling off very easily from the retroperitoneum. So the plane is very important while dissecting kidney of the retroperitoneum. So after doing completion of nephrectomy, you just put it in a retrieval bag and take out the kidneys. So after performing good numbers of radical nephrectomy or simple nephrectomy, laparoscopic nephrectomy, you can venture for the partial nephrectomy. Partial nephrectomy is one of the procedures that should be done laparoscopically or minimally invasive, because you'll avoid, unlike radical nephrectomy where you have to remove the kidney, you have to make incisions. Partial nephrectomy you can manage with a simple, for the retrieval of the specimen, just the port is enough. So partial nephrectomy, I think, should be done laparoscopically or by any minimal invasive the way. These days this is done basically by the robotic surgery, but because we don't have a robotic, so we still manage with the laparoscopy. So if you see this one, so to reduce the time, the ischemia time, we part the sutures before clamping the artery. So you just clamp the artery and then start looking for the renal mass. So you clamp it, your one ischemia time starts now, and then you've already identified your renal mass. Then you start resecting the renal mass slowly. You see, once the artery is clamped, there is a minimal or no bleeding from the renal bed. Slowly, you just keep on cutting the specimen with the scissor. See, the renal bed is not bleeding because the artery is clamped very properly. So this is the renal bed now. It looks perfect for suturing. Then you start suturing the renal bed. This is my one of first video. So where I have sutured the renal bed only one layer, but theoretically or in practice, actually renal bed should be sutured in layers. So this is my one of the first video. So just one layer closure of the renal bed is done in this video. So these days we are doing 2-layer closure of the renal bed. So this partial nephrectomy is, I think for a beginner, is one of the difficult procedure because you are dealing with a kidney. If your senior time goes beyond the limit, the kidney might suffer, the kidney may become non-functioning. So this is one of the, for a beginner, it's one of the most difficult surgery to perform because this procedure is being done by robotics in many centers nowadays. We are still practicing laparoscopy because of our limitation and constraint. So this is the closure of the defect and the So as a closure of the defect, this vascular clamp is removed, and you can see there is no bleeding in the renal bed. So thank you very much.
Thank you very much.
Speakers, I request our chairpersons, Pradeep Vaidesai and Baburam Pongal sir, to kindly present the certificates and the mementos to our esteemed speakers. Rasan B. Singh Kalsagasa and Mahesh Adhikari.
Everybody comes to क्या हाल चाल है ठीक हो थैंक यू सर सही सही क्या हाल चाल कैसे हो कल आपका चुनाव है Good.
definitely say that now this one is retired. So that's what is there. So, but I think it's a very interesting topic. But I don't think I will justify this topic to everybody at this point of time, because I was just at the tip of the iceberg in artificial intelligence. It's a very difficult topic. This is my slide. It's my benchmark slide, I said. Previously, I said, if you want to be a good clinician, you should have all three limbs strong enough. Otherwise, you fall down like a tripod. But I think after reading or going through all this artificial intelligence, a couple of things is not needed now, like attitude. The machine doesn't know the attitude at all. The only thing what is left is knowledge and skill as a data. That's all. And okay, I think before I go to the subject, what is intelligence after all? We have to understand that's very important. So these terms will come very frequently when you talk intelligence, like perceives, analyzing, data analyzing in the environment, or understanding, learn, use of knowledge and skills in different situations, problem solving, understanding of the words, or verbal fluency, numerical or spatial abilities, or reasoning, memory, and perception. If you have all these qualities, then you become intelligent. So now, the intelligence might be we human beings, or might be machine even nowadays. So if the machine becomes intelligent, then what you call it artificial intelligence. So this is a topic I'm just saying. I've tried to go through the literatures because the development is so fast that 2019 literature is outdated in 2023 in respect to the artificial intelligence. So fast coming out, especially in these 2-3 years, that those articles, if you review the old one, doesn't make sense now. So, if you have got all the qualities of intelligence in a machine, I told that this is what known as the artificial intelligence. But having said that, they are more precise than human beings. They are more accurate, appropriate, and foresighted than human beings. Then it becomes a real AI. So back to history. In 40s, somebody thought that machine thinking human beings. And the Turing test is that if anything, you can't differentiate between human and the particular machine, that means it's artificial intelligence. That's the basic concept. Then John McCarthy just coined this term artificial intelligence. Then there are ups and downs. Because you know that all those the new things that comes is in hands of business people or government. If they fund it, it will come up. If you didn't fund it, it will come up. So the same thing happened to artificial intelligence. In 74 onwards, you see, this is not an AI winter because there is no funding at all. They have to stop their research. So this thing happened in later on also when I'm not skip the slide. Even in 83 to 93, there is a second winter. They didn't see any scope. They didn't thought that it will be enough income generating or good for them. Even the government, they just didn't fund at all. That's why AI was not in that time in good picture or good in a talk of town then. Then afterwards, probably the Japanese were the one who invested and interested in AI much more than other countries. So in early part of 20th century, you see, these things were promoted by Japanese and they invested a lot of things. So according to that, a lot of other countries, people, government especially, and there are big entrepreneurs or big business houses, they invested and it came out with a couple of things very important that like data mining, and they use them mostly in the industry or in not human, what you call business. So we know that this started in medical diagnosis also in initial stage. Otherwise, They are all in the business, other business, they were using this AI. So what happened that they become so talk of town, so important, because there is a very magnificent, sophisticated, very sensitive machines which can store a big data, might be in millions of scope, and that makes this AI is very important and very top of town after 2011. There is still graph. You can see that. You see, till 2010, not much of improvement in the scope of AI, and there are not much of papers you can see. But within this year of 2010 onwards, you can see the steep rise of interest of the people or scientists, and a lot of papers came out, and a lot of importance and use of this AI was noticed in this 2023. So I have gone through a couple of or few articles of 2023, which is completely different than those one even in 19 or 18. So these are all different types of artificial intelligence. They are all machine oriented. They are all machine. So one of the subtype is machine learning. So they utilize the analysis on multiple sources or data, including diagnosis or treatment lab, and they predict the prognosis. So easy. You feed up the data, they will tell the prognosis. And it's almost accuracy is 93% accuracy in machine diagnosis also. And the basic thing that they recognize the pattern of the data. They segment them. They just classify them and segmented them, and they understand the data, and they can interpret and analyze. So this is quite. They found in 20s that it is more efficient, more effectiveness, especially in the MIS surgery or MIS procedures. So the other type or subfield is deep learning. They are more complicated. They are multi-layer statistics data. They what you call in the machine. So they are interconnected, and neurons. These are all small nodules. They are also known like neurons as a human brain. So they are interconnected, and they are in multi-layer and more complicated. So how their deep learning was invented. And they recognize the speech and object detections. I'm speaking here, if they are recorded, they will be recorded there in somewhere in the main computer data. So they can classify the images, and even they modify the images. If you give multiple picture of under some picture of some patients, they might get converted into three-dimensional patient. They have got that capacity to make three-dimensional out of two-dimensional pictures. So that was how they used in giving the output. And the third subtype, even in the field of pathology, they are so much trained. They have given such a big data by the pathologists. They can detect the smallest nodule or might be cancer cells that pathologists can't do that. So there is chances of missing is very, very less. The error might be minimized, especially I'll come to that point. Even diagnosis can lymph node metastasis. The pathologists, if they miss it, but they can find out. So the error of identifying the cancer cells has gone down from 3 or 4.5% to 0.5%. You can imagine the difference, how they identify by the help of machines that pathologists can't do that. And again, the same thing in 12 to 15 time, the capacity of the importance of this AI was so prominent because of incredible increase of the computer power, speed and capacity. And on top of that, the big data, they fit them, there are these two things made the AI more important, more what you call accurate, giving their output. So they have got the human mind type. When they use their data or their machines, they can even learn by themselves by mistake and or success. Like what we do in human trial or error, we learn by doing a lot of trial and errors. We learn a lot of the same thing. They can do these unsupervised sort of readings. They can get it, though they are not being input by the human beings. So they are the one who can interpret things of their own even sometimes. This is very interesting that even they correlate the old data, they remember that old data, and they try to compare without the different correlation between these different things, and they interpret on the basis of the data they have already in the past. So the previous correlation they remember and give. Like just I said, I have seen this case long back. It's what light did. So this must be the appendicitis. I thought it's not the wrap-up momentum. So if it came out with a wrap-up momentum, then this AI will give the example of, and they correlate things they had in the past. So they remember things as we remember. I will correlate in sometimes. Oh dear. So again, this one of the type is neural language processing. They understand human language, and the language they understand probably in all over the world, mostly the English. But there are some countries where they have got their own language. So if I want to have in Nepal, I must train them in Nepali. Otherwise they will not understand. Otherwise they understand only English. And this is how they understand. Okay? And they comb the record, especially from the medical records and operating notes and everything, and they can tell us and detect the adverse event with those notes only. And it's almost 100% correct and 72% specific. And again, you see, they communicate it by writing or reading all of things, and they recognize the speech, they synthesize the speech, and they translate even and extract the points what they needed. So these are all the applications that you can do in daily, day-to-day life since morning to evening. So then artificial nature, this is a human brain sort of arrangements in AI. So this is a biological neural system similar as brain. So what they do is they accept the input and store the information and interpret and pass to the next level, and their prediction is so correct. Even Apache store that we get in pancreatitis have got better result than what we do in Apache score than AI. You see the sensitivity 89% and especially 96%, where Apache store in pancreatitis is just 80% sensitivity and 85%. So that much accurate. They give the prediction for not only this. There are so many others. This is a typical picture of a AI. So there are the neurons. These are the neurons. That's the nodules in the layer of the deep learning. So when you put the input there, everything, ANN, NPL, ML, DL, everything they work together and give you the output, which is very much corrected in time. And the most important thing that is very interesting to us is computer vision. So once their data are there, the camera can read it. All the sensors, they can read it, even from the cameras, microphone, or...
Sir, you've got 1 more minute. Thank you.
Really, sir? Okay, sorry. And they recognize the object and achieve human level capacities. this augment and enhance the ability to perform some of the surgical procedure even because of those visual data. And I don't have to go much. You see this changing pattern in surgery or patient care, or they can monitor even vital information during the surgery even. And they can spot out minor things that radiologists or pathologists have missed it. And there are a lot of places we can use this artificial intelligence feedback. So pre-operatively they give all diagnosis. Even they can tell us whether this patient is fit for surgery or not, whether this patient will have any complications during operation or not, or post-operative. So that's much of information we gather from the AI. And even malignant, they can tell us whether this fellow will, after surgery, will have good result after chemotherapy or not. Intraoperatively, this is a lot of tension that we get, the burnout is reduced, and they can map out, they can tell you that about the lesion even the most important that they can tell us that what are the structures just beside these lesions, whether you can operate it or whether they can or not, whether big vessels or any organ is beside that lesion or not. So they tell every steps by just doing the three-dimensional picture and the relation of the lesion to the anatomy beside. And as I told you, this can tell this, I'll take just a minute, I'm very fast. Intraoperative, even sometime, if you are wrong in steps, the AI will tell you you have gone wrong, you do this way, or about your surgery. They have that much of directions they can give by their data analysis. I'm going to do this. Well, they have got a big role in what we call training in surgery. Like simulations is the one that gives a real feeling. Well, that's good for, I think, in low income and middle income countries. If you can have these simulations, that will be very much good for the learning students or junior doctors, and they will understand in real time. So I'm not going to talk about advantage and all this intelligence because we have already talked that. So this all reduces human error and risk, and they are unbiased and they are available all the time. We have to give time to our family, might be girlfriend or boyfriend, whatever it is, but they don't have to give any time. You can repeat and repeat anytime, 24 hours a day. They don't get tired. So that's the benefit of this thing. And I'm going to talk about this. And definitely there's a bridge between the surgeons who are learning because they guide real time during the operations. High cost, no doubt. And the ethical I'm going to talk just in 15 seconds, Sunil. So there are a lot of limitations, no doubt. This is not the magic bullet, good, answered everything. Ethically, there are a lot of questions that is raised by a lot of papers that who is responsible if something goes wrong by AI. Is the operator, is a manufacturer, or hospital, or who is the one? That's very a question of a lot of debate nowadays. And hacking data, it might be the privacy might go off, or sometimes inadequate or not proper data might give a wrong decision. So I'm going to talk about this implication of surgeons. But the role of surgeons is very important here, because if you don't feed data to this machine, they can't give a good result, good outcome. So we must give a good data, appropriate data, standard data to get a good answer out of this AI. Otherwise, they will mislead us and we have a lot of accidents. So now, and this is not only the medical person who can do it. The engineers, the electronic engineers are also a very important part of this endeavor. So we have to feed them and we have to work with them simultaneously or vice versa. Otherwise, the data that will get it will be wrong. I think last slide. I'm not going to talk all these things now. So I think we have to consider because of from the low-income countries. So we have to have how to have this technique, this the advance of science in our practice. This is very important because our part of country, part of the world, our data system is not that accepted by the, higher level Western countries. That's why probably we might have our own data or own feedback to the machine so that we can use those benefit of AI in our country or in this part of the world. That's why otherwise all the data we are getting from higher centers may not be fit into our countries or to our area. That's why we have to be very particular in this matter. So that's all. I think I tried to finish in time without stopping.
Thank you so much, sir.
Organising committee, especially Dr. Nip Joshi, for the opportunity to speak at the 15th International Congress of the Society of Surgeons of Nepal. This will be a quick waltz through a bigger topic. I have no conflict, but I do feel an anxiety of being someone obviously from a higher income country, and the talk that I give will have a different flavour to the same talk given by someone from a different type of background. So please excuse me for that. I have to say, I was trying to work out my place in the world here, and we are enthusiastic observers of the SAARC countries, including Nepal, and will remain enthusiastic observers as long as we can. You have marvellously high mountains, and we have very long barrier reefs, and I've been pleasantly surprised how many people know where Brisbane is, so thank you so much for making me feel so welcome so far this weekend. So global surgery, it's a large subject, and I'm just really going to address the breast cancer moiety of this, and I'll try to get through these things in the time allocated. So the definition, really it's a bit like frailty in patients. Everybody kind of knows what it is, but it's just so hard to define properly. But there are elements, there are always elements of inequitable care, and there's always elements of international health and elements of explicit focus on low and middle income countries, and especially to do with systems analysis. Thankfully, a lot of work has been done in the background, and this is so well addressed this morning by President Sharma, talking about the Lancet Commission on Global Surgery and how ambitiously in 2015 they set targets for 2030, and they worked out that really there's a deficit of about 143 million procedures worldwide that need to be catered for, with a deficit in surgeons at present. There's, of the 330 million procedures which occur per year, only 6% occur in the poorest countries. So they set targets there to do with seeking care, reaching care, that everyone should be within 2 hours of effective medical treatment, and receiving care. Quite ambitious with a 15-year target. And then they went further than that, and they talked about what sorts of operations should be given by all countries, and which ones are must do and which ones they should do. So high purity, high throughput ones such as laparotomy, caesarean section, and treatment of open fractures are called bellwether procedures. I think you're familiar with these. And I was happy to see that in the should do was slightly more complex with gallbladder surgery was mastectomy. So breast cancer is definitely on the agenda here. The burden of disease of breast cancer is very high. So 1 in 4 cancers diagnosed around the world is breast cancer, and accounts for many new cases per year. The incidence varies across the world, but the mortality is the thing that we should be working on. The mortality is the thing that is inequitable. So 1 in 4 cancers diagnosed around the world. The incidence seems higher in the well-off and the well-educated. However, the mortality does vary a little as well between countries. There's a variation in mortality between 10 and 25% for breast cancer, and one can see, although the incidence is higher in some Western nations, that the bulk of the mortality occurs in the Asian countries. And the mortality is the part where we need to focus on for inequity. So Nepal started to GloboCan and to UICC, and one can see that the incidence of breast cancer is rising in Nepal as well. So barriers, with the ideas of equity, it's all to do with barriers. So I think we're familiar with the diagram on the left. It comes back to things as simple as hand washing, running water, education. There's always an economic element to these things, and just surgical parts of this would be, by themselves, would be, without a systems approach, would be somewhat minimal. So there's research gone into what are the barriers to stop us reaching equity with all these things, and fairly complex analysis done by large organisations. But in the end, it really just come down to systems which are either enabling or preventing or making barriers to equitable care. And it comes down to really the initial slide I showed with the systems-based approach to avoiding inequities. So moving from really just identifying barriers to what can we do to improve the situation. So cancer control strategies, I mean, these have to be curated. There's a lot of great work done with this. The lower income countries suffer from patchy cancer treatments, not radiotherapy in every country. Middle resource and higher income suffer from lack of registries and lack of quality assurance. And so resource appropriate prioritisation is really the right approach, and that's what the World Health Organization went with when they announced the global initiative on breast cancer. So with community engagement and overarching business approach and working with current governments. So thankfully, this project is something that has a structure already, and that they worked out that in countries that have a cancer control initiative, the mortality rate from breast cancer falls. So this is an overarching cancer control effort, and they've worked out that moving from late presentation and patchy treatment to a system whereby people present earlier and the treatment is completed, that you could get the maximum risk-benefit analysis there. So they come up with 3 particular initiatives, or 3 tiers of approach. So 60% of people diagnosed at stage 1 and stage 2, so earlier diagnosis, that's quite achievable. Breast cancer is, unlike other organs, that can be palpated in the clinic. 60 days to diagnosis, that's a challenge for the laboratories that we have, and 80% of people completing their treatment, and it comes down to this pre-diagnostic interval, the diagnostic interval, and then the treatment interval. And from work done in Africa, they've shown that clinical exam, rather than a self-breast exam, so examination by a clinician will get you the most benefit for the minimum input there, until it's possible to move to even better screening processes where the decrease in mortality. This is a population-based screening. So, but as far as early detection goes, clinic-based exams will get to around about 60% early stage disease. So the timely diagnosis is one thing, the identification is one thing, the timely diagnosis within 60 days. There really is a sweet spot here between the access to the patients, which is often in the dispersed setting, as opposed to the quality of the laboratory testing, which is often quite centralised, and it's well documented in the global health paper by Mira, talking about the effect of community workers at one edge of the equation versus what's available in the tertiary referral hospital. Ideally, for most diseases, there'd be point-of-care diagnosis in the community with a finger prick, but sadly, we're not there yet. Comprehensive treatment completed in 80%. This is rather aspirational, I have to say. In most countries, this doesn't happen. And treatment of cancers, and in particular breast cancers, is multimodal. Medical oncology, radiation oncology, and all the supportive care, including the psychological well-being and the survivorship issues of premature menopause. I mean, these are really long-term efforts. Not to be dissuaded, the World Health Organization has put it all on a page, from early identification, early diagnosis, and 80% of people getting to the end of their treatment. They've also given a a monitoring process as well. So here's the next part of it. If you think you've introduced the right things, how do you show that you have done what you said that you were going to do? So this is quality assurance and registries. I'll just share with you a story from Australia. We have healthcare, or these atlases of healthcare variation. Our country is very centralised. We have large patches of decentralised population. For example, in my state of Queensland, the T1 mastectomy rate, that's mastectomy is a first operation for T1 tumours, varies between 10% and 40%. That's just in my own state. And the access blocks, we think in particular with some communities to do with people having a distrust of hospitals, in particular our Indigenous population, that they call breast cancer a don't come home disease. You go to the hospital and you don't come home. And we, through a Breast Cancer Foundation, have studied that, and the role of the Aboriginal health worker or the community health worker would seem as valid in the Australian community as in any. We published on that as well. So what about optimal care pathways? I mean, these are really aspirational things now. If you want 80% of people to complete their treatment, you have to measure what you've done. And keeping in mind that from our country, we're obliged to measure these things frequently. So we've looked at the treatment intervals as outlined, 4 weeks to surgery, 6 weeks to start chemotherapy, 4 weeks to commence radiotherapy. And we looked at a cohort from early in the 2000s with at least 5 years following, at least in the 2010s with at least 5 years follow-up. And amongst the causes of excess mortality, apart from no positive disease, you can see that taking a long time to complete the treatment is associated with an increased mortality. And just based on the guidelines, we demonstrated that if you went beyond the 4 weeks between diagnosis and surgery, beyond the 5 weeks to commence chemotherapy, and then beyond the 3 weeks to commence radiotherapy, the excess mortality was in order of 43%. I come to the last parts of my talk here. NGOs, part of what I represent here today is from an NGO. So non-government organisations, there are a lot of NGOs around the world, and I appreciate that people who go into this work are very well intentioned, and they do supply a lot of equipment and a lot of expertise to low and middle income countries. The work is often fragmented, and sometimes the equipment that they bring to bear is outmoded and doesn't have any kind of long-term plan. So they're deeply in need of coordination. There are quite a few. I bring to your attention the G4 Alliance only because a good friend of mine, Neil Wetzig, is in the leadership pathway there. They look at the 4 common areas of surgery, obstetrics, trauma, and anaesthetics, and they are one group that would at least try to provide some umbrella over the work that they do in the same sense that the World Health Organization does. So the Royal Colleges play a particular part. Many of us have studied in other Royal Colleges. In particular, our Royal College is bound by the rules of engagement of the Department of Foreign Affairs and Trading. So we have effectively become an agent of theirs. We do get income from bequests and other fundraising. And to be honest, the countries which we visit, they would have particular needs, and they would really prescribe to us what they want. So they want 100 ENT operations in Vanuatu 4 times a year or something like that. It's our role there is kind of downstream from some of the larger decision making there. And I would just say that our rules of engagement are particularly defined by a government, and that's about increasing the capacity of the local population and all the other various behavioural rules that go around it about just good medical practice and not abusing the privilege of where you're working. Having said that, we're a small group but enthusiastic. That would describe Nepal as well, I think. And we've been able to fund quite a number of scholars over the years. I'll point out the ASC 2003 International Traveller Grant to one from Nepal. So we've still got a future here, that's good. So the conclusions here, the conclusions of someone from a higher income country, and so the global surgery, the enterprise of providing improved and equitable surgical care of breast cancer, building on the work from the great President's lecture this morning. So there's still a need for this group, with 1 in 4 cancers being diagnosed around the world, an increasing need. The World Health Organization framework focusing on early detection, diagnosis and treatment is a very good yardstick. Barriers exist in all countries. I think I've shown that they exist in low and middle income countries as well as high income countries as well, and the framework works just as well for both those sets of countries. And I could finish up. I know other people are advertising surgical meetings, but Brisbane will have the Olympic Games in 2032, so start training if you haven't started training already. Thanks very much.
Like you rightly said, that completion of treatment, I think in Nepal is much lower to what you've shown. So, thank you very much. Any questions from the floor? Okay, I think we will continue again.
He represents one of the B of BNB Hospital, again needing no introduction. He is my guru, and I was fortunate to have had an opportunity to work under him for more than 12 years. And I found him as a rare combination of outstanding dexterity, excellent and exceptional intelligence, excellent training, and a sense of humanity towards his patients, staff, and junior. From this year, Society of Surgeons has started a new chapter where we will hear from our seniors the ups and downs, achievements, and we expect more than that a blessing to us. Professor Vaidya is always up to date, not only in his style and outfit, but also at knowledge, skill, and attitude. So I invite Professor Dr. Vaidya for further presentation.
Just before you start, this is something that we've started from this year, a new series of journeys of our seniors, how they've struggled and how they've contributed to the development of surgery in Nepal. And I think the executive committee thought that Dr. Vaidya's role in promoting general as well as especially urology in Nepal has been outstanding. So we've thought that we should give this of our first series, and we'll be continuing this in our next international conferences again. With this, the mic over to Dr. Vaidya.
Medical College, Amritsar, 71 finished my internship, came back to Nepal, did a surgical residency and went to UK. Finished my FRCS Edinburgh in 1976-77 and from Royal College of Surgeons of England in 77, and I had the good fortune of working as a post-fellowship registrar in Royal Infirmary Blackburn. Then I somehow, where I did 3 years of general surgery and pure urology for 1 year. Then I came to Charing Cross. At that time to go into the teaching hospital for a black face wasn't very easy. I was lucky, and I had the opportunity to rotate with the Eastbourne doing urology, and had even in those days, 77, though I was a post-fellowship registrar in urology, we had to cover the general surgery. I had thorough training in general surgery before, so I was actually covering for Professor Rain and Professor Pandawar, both of them, of course, you know the name, examiner to the Royal College of Surgeons. I came back, I got short, I came back to Nepal in 1982, then my struggle started. Because in government there was no lateral entry, so I was given a house officer's job in 1982. In general surgery, there was no urology department. So, general surgery, house officer, acting registrar to rotate with different senior surgeons for 2 years. Then I will be sent to outside Kathmandu and as an active surgeon. First will be of senior house officer. Anyway, I had a ticket in my pocket where I was given a consultant job in Plateau University, Nigeria, and also applied in Brunei, where I was also given a job of surgeon. And but I was determined to come and work in Nepal. Well, I didn't take that SHO job and joined the mission hospital where I did my residency back in the 70s. I had the advantage that there was no urological as a trained person in Nepal. I started endo-urology in Nepal in 1982. Whatever saving I had brought all the equipments, including the diathermy machine, the light source, everything. So the bladder tumor and prostate, which was done by open means, I changed that into endo-urological service in Nepal. It was very difficult to train the juniors. You know, when there was no audio visual like this today, but one of my consultants in Eastbourne, Mr. Perry, he retired and unfortunately developed Parkinsonism. He was so kind to send all his TUR sets as well as the teaching aid. Those days, I don't know any of you have seen, rigid teaching aid and the assistant moves wherever the surgeon moves. And he sent that to me so I could teach my junior in Patan Hospital. This is the photo of actually Patan Hospital where I spent 20 years as a surgeon urologist and salary was 1,500 rupees, maybe $4 a month, whereas I had given up 300,000 rupees in Brunei. I had to do something. So we decided that we should have a private place to work and mission hospital, no private practice. They broke the rule and allowed me to do the private practice after hospital hours, that is 5 o'clock, not 2 o'clock, 5 o'clock. So I started, that was the first of its kind, the small private setup in downtown Tripureshwar. It's called Kathmandu Nursing Home and it was of its kind in Nepal, first one. So, but it was so shabby and everything was basic. There was no drainage, no water supply, the electric supply is so erratic, you will be surprised. 3 of the royalties had their operation done there because there was no other private facility. And then we decided to build a hospital and me and Dr. Banskota, BNB, we laid the stone foundation ourselves and erected the building. Yesterday, if some of you who attended the pre-conference meeting might have seen the 4th extension, because we didn't have money to do surgeons, we had to do it in parts, first parts. I finished the 4th part now and that's what it looks like now. That's my new operation theatre and we have a total 23 operation theatres and 9 of them are modular, that is from Italy. And this is, I said I had to do urology and general surgery because no urology department in Nepal. So, this is, we call it the Dhana technique. We see this laparoscopic cholecystectomy is being done and from the right upper quadrant port I have put the ureteroscope through the cystic duct into the common duct and in those days no lasers. So pneumatic lithotripsy used to break the stone of common duct. You can see Dhana in there standing as well. So, it was a difficult sort of situation. No facilities. In Patan Hospital, a child with diphtheria goes to the communicable disease hospital, no operation. Then goes to Beer Hospital, no operation for children. Then goes to teaching hospital, again no children's operation. then goes to the Kanti Children's Hospital, only one hospital where the pediatric surgery is done, no anesthetist. That was the chronic disease for so many years of Kanti Hospital, no pediatric surgery. By the time they come to Patna Hospital, the child is already dead. So we had made the protocol that any child with diphtheria or any foreign body in the trachea, he doesn't get registered in the emergency, goes straight away to the theatre, wherever I am, at home, in my private clinic, doing operation, I will be there in the hospital within 15 minutes to do the tracheostomy or remove the foreign body. That was the protocol. I started with Professor Neelam Adhikari, and these days, thank God, the diphtheria incidence has gone down. In 1990, the Royal College of Surgeons of Edinburgh, they appointed me as their tutor in general surgery, and in 2099, I was given awarded the visiting professors in urology by the Royal College of Surgeons of England. And this is 2002 picture. I was given FCPS without exam in Karachi, it was, and the external examiner, Professor Chaudhary, I'm sure the Pakistani representative would know him very well. You are the president. He visited BNB and he said you could be the preceptor in general surgery as well as urology. So I started FCPS program in 2002. In general surgery as well as urology. There are quite a few graduates, and in between I had the opportunity to become the professor of surgery and urology in a teaching hospital, Kathmandu University, as well as KISS Medical College. This is the medical students. Then, there was no urological society in Nepal. So in 2005, 16 of us gathered in the hotel, and we decided that there should be a urological society in Nepal. And I was appointed the ad hoc president, and then I continued it for 5 years. I should give credit to Professor Sasidharan. He is a professor of urology in Manipal Hospital. I'm sure all of you would have heard. In South India, my son was graduated from there, so I knew him. So I was the president, but the introducing the society to international community wasn't easy. Then I attended the first meeting of UA in 2007, and there I come across all the members from Hong Kong, from Singapore, from Bali, etc. And then I said, I am representing as a president, you should also invite the secretary. And then we established relationship with Japanese representatives, and we explored gradually. They offered us a visit to Japan. I think Dhamma is the first one to go to Japan. I attended there as a board of journal, editorial board of the Urological International Journal. And K.T. Fu, I don't know if you have heard his name, he is from Singapore, and now he is almost retired. He is the very senior most person in Singapore, and he also helped now to promote. Now, in the meantime, see the postgraduate training program, I was going to FCPS in, I think it was in 2007. The MCS program in urology, the general surgery came up to stalwarts, and my good friends, Cockrell and the Professor Joshi, they are there, and they started the program. And the height it has reached today. And in 2011, it was the first of the gathering of this size. I mean, today it looks routine, but that time I arranged the first Asian Indo-Urological Conference. There were representatives from most part of the Asia as well as from abroad. And from BN, it was done in Solti Hotel. So for live telecast, I had to, finance the laying down the cable, black fiber from BNP to Solti Hotel and from teaching hospital to Solti Hotel. It cost me 1 million rupees. Anyway, the conference went very well. The live operation by the international faculty as well as Nepali faculty, and this was kind of conference first time in Nepal. And the NAUS, which is very dear to me because I started it, and I have started the oration 2022. Professor Malika Arjun from India gave, and 2023 Oliver Taxer from France, he was kind to give and talk on RIRS and literacy. The NAUS building, which I was lucky enough to be able to finance, they were very kind asking me to inaugurate it, and the Lifetime Achievement Award by NAUS, by Surgical Society, Beer Hospital, Army Hospital, and the then Prime Minister Girija Prasad Koirala. Now, you see, what was the primary goal? Primary goal was to serve our community, rich and poor. I had that opportunity working for 20 years as a missionary in a mission hospital, and now for 26 years in a private hospital. Working environment was terrible when I came in here. Now, took the challenge. You can't look at the government, now government will do us. Took the challenge in our hand and created opportunities for the newcomers. Now at BNB there are 217 doctors, 30 orthopedic surgeons in one department, and we lacked that opportunity. Now we are in a position to give that opportunity. Against many odds, it's a private hospital. So, however, we managed to participate and contribute in training, education, and skill development of younger surgeons. Not only skill development. When we start a private institute, we had to finance from our pocket to send the guys for training in Pakistan or India, Bangladesh, China, even we send one to UK through the connection. And you don't have to pay all the time from your money pocket. With your connection, you can have the sponsors around the world. And I also sponsored the MBBS programming. Brilliant guy in teaching hospital. I stopped doing that because the telephone call I got from him was from America. Sir, I am in America. I said, no more financing for these MBBS graduates. Now the beneficiaries, some of them are in the audience here. The young surgeons, now they are playing a leadership role in different institutes of Nepal, rivers, immigration. The charity starts at home. I am so proud that though they are born in England, all my partner, Dr. Banskotra's family are here, and they are happily serving the Nepalese people. I hope I will set an example, and I am creating the platform. And am I happy? Yes, I am happy. To become happy, you got to have a good health. You got to have a good family. You have got only one son and he is drug addict. What sort of life would you have? You got to be satisfied in what you are doing. Professionally, I am satisfied. At the end of the day, you need some money also. The God has been so kind to me that I am well off. Now, the last slide I would like to show you is, before that, 1 minute please, 2 minutes. One little story. 20 years back, I was the chief of surgery. It doesn't matter. On the ring bells and I will be in the hospital within 5-10 minutes. 19 years old boy brought by the police. The registrar was panicking and saw the child is dying, and he did ultrasound, there is free fluid and not fit to take to CT scanning, chest x-ray was all right. I came there, I said, I want to do further resuscitation in the operation theatre. I put the catheter, no urine. Blood pressure was 60 or something. He was still conscious, no visitors. So I asked the policeman to sign the consent form. And he was so hesitant. I said, I will also sign. So I countersigned, I took him to theatre. Anesthetist wouldn't give the anesthesia. Look here, we are losing him. Before that, I sent my ambulance to blood bank, and my personal car, I gave it to the nighttime staff who was good at driving, sent him to Bhaktapur to collect the blood. Those days, no blood bank in BNB. And I took him to the theatre for resuscitation. I took the knife in my hand after scrubbing. Anesthetist had to put the tube down. You know, I opened the abdomen, there was blood everywhere, collected blood in the bucket, put the double layer of gauze. In those days it was the glass bottles, you know. So you filter it, I did the auto transfusion. And in the meantime, I had gone through, the spleen was shattered, so I removed the spleen quickly, and you know, and there was a mesenteric tear, but the bowel was okay. So we closed that and packed the splenic bed, went through the liver, the stomach, the small bowel, large bowel down to rectum. I was going to come out. I had to look in there was a small hole in the bladder. That's why the urine wasn't coming out. I thought there is no blood pressure, no urine. Anyway, I closed the bladder and came out and finished the operation. Blood pressure started coming. His hemoglobin, by the way, was 2. And the blood also arrived. We gave him. Next day, went around straight to the ICU, and there were 10 visitors. 2 o'clock in the morning, no visitors. Now, look at here. Patient survived, otherwise what would have happened? No consent form, no blood being arranged, and the auto transfusion which I gave was mixed with the urine. Luckily, the patient survived. And so, you know, not me, there is somebody else who's look after us. When you dare, look at this X-ray. This patient was brought to us from Bhagwanpur. See, look at from the left side of the chest, the rod has gone in because he was constructing a building. A field fell down and landed in that. They used the hacksaw to cut the rod and brought to BNB by an ambulance. And it was coming out of his right eye. There were thoracic surgeon, vascular surgeon, ENT surgeon, orthopedic surgeon, general surgeon, the facial-maxillary surgeon, and ophthalmic surgeon. We didn't have to do anything. General surgeon made a little nick on the left side of the neck. We could feel the rod, took the hacksaw, divided the hacksaw, pull the rod from lower end, lower half, from the eye, top end. Patient survived. The thing only needed was the chest tube for 2 weeks. After 2 weeks, that time actually I was in the European tour, so when I came back, I knew when I was in the aeroplane, you can get the telephone call in business class. So my son gives me a ring, this is the situation. I came back, patient was ready to go home. His eyesight was 6/6 and you can see slight edema on the eyelids on the right side, that's all. No other problem. We all do, we work, but there is somebody else who gives the blessing, and thank you very much. I am nobody, just a simple servant.
Sir, please be on the stage to present the certificates and token of appreciations to our esteemed speakers. And Jagdish Lal Vaidya sir. Sir, to please come up on stage to present the chairpersons of the session with token of appreciation. Sir Rupaketi sir to escort Harit Chaturvedi sir to the stage, positioning him beside the chair.
This is the first oration for the day, B.N. Rana oration, and I would like to introduce the orator, Dr. Harit K. Chaturvedi, who is the chairman of Mac Institute of Cancer Care, a renowned figure in the field of surgical oncology, has a fame beyond borders. I would like him to sit in the chair till I introduce, and has a fame beyond the borders. His expertise extends to cancer care with a focus on breast cancer, head and neck oncology, thoracic oncology, oncology. Dr. Chaturvedi has earned his MBBS and MS from Ganesh Sankar Vidyarthi Memorial Medical College, Kanpur, MCS from MGR Medical University, Chennai, India in 1992, before joining Max Healthcare. His mentors, Dr. Krishnamurthy and V. Santa, were his inspiration for him to go into the surgical oncology. He joined, after finishing his training in surgical oncology, he joined, in 1995, he joined Batra Hospital. Till 1999, he was there, and in 2000, he joined the cancer group in Apollo, Indraprastha Apollo Hospital. And then he joined Rajiv Gandhi Cancer Institute in New Delhi from 2004 to 2009. And he came to Max Hospital and incepted the Cancer Institute in 2012. The institute now has around 100 cancer surgeons who is working under him. They have, last year only, they have done around 28,000 cancer cases in their center combined, and they have 85 international peer-reviewed journals in combined. In addition to actively participating in live surgical workshops, Dr. Chaturvedi has presented his work both nationally and internationally. Numerous peer-reviewed journal articles reflect his abundant knowledge and his dedication to furthering our understanding and treatment of cancer. He served as the president of Oncology Forum and is actively involved with Indian Association of Surgical Oncology, ISO, and Indian Society of Society of Oncology, where he was a president in several different eras of the year. He served as an executive member of SFO and ACOS. Dr. Chaturvedi established the Core Cancer Foundation, which is a non-profit organization, in 2004, and had worked for raising tobacco awareness in schools. He is a multifaceted person who enjoys reading and finds comfort in quality time spent with his family. We honor his contribution to oncology today, recognizing his skill as a physician and his compassionate healing, which exemplifies the best practice in medicine. Thank you, sir, for being here, giving us an oration in B.N. Rana oration, and I'd like to call upon my president, Professor Sunil Sharma, to hand over a medallion to Professor Dr. Harit Chaturvedi to start his oration. Thank you.
The President and the EC for inviting us here, and actually the privilege to deliver this B.N. Rana oration. So, in the journey to discover about Dr. B.N. Rana, I learned a lot, and that is where I realized that, that one need not be in the place where you want to serve a change, bring a transformation. So B.N. Rana was born in Nepal, but actually he spent all his professional life in Germany. He was the son of Brigadier General Bhakta Narsimha Rana and Devi Kumari Singh. He had his graduation from Delhi, from where I come. I bring greetings from there. And then subsequently went on to Heidelberg University to do his graduation, and where he did his neurosurgery training in 1978. And then he continued with that, and he worked in the hospital where he became a director. They invited him to become a director for a tenure of 10 years from 82 to 92. Following that, he retired from the government position, and thereafter he has continued in practice, and at the age of 87 still he is pursuing his work in serving the society, and at that age also he is running a clinic. So that was his professional life. But as a human being, as a Nepali who wanted to serve his people, he has been continuously coming back to Nepal year after year and serving people at large. And what I got to learn, that not just working in Kathmandu, he even worked on to remote areas, supported healthcare institutions there, provided ambulances, and making sure the poor also have access to care. Something what Dr. Beer just now shared, that how he has built his service. Likewise, he was a person who, his heart was with the people, in the service of the people. And obviously the bearer of science and fusion of science and service made the person he was, and that is what made all the transformation. And for all this, he was awarded the Gorkha Dakshin Bahu Award by the late King Bir Bikram Singh, and his true love for Nepal actually cannot be measured, but such people bring transformation which transcends for ages and inspires people for generations. So it is really an honor, and I thank the Executive Committee of SSN to give me this privilege to deliver this oration. And on delivering, while I will share parts of my journey and my experiences of as a surgeons, how we can transform oncology care in our communities and societies, I really want to say that even the life of Dr. Rana has inspired me a lot and going through this. So I bring greetings from Max Oncology team, the Max Institute of Cancer Care, and the Max Healthcare, which is one of the largest chains of multi-specialty hospitals across India. We are predominantly in the NCR region. We also have a Max Nanavati Hospital in Mumbai, and one in Mohali, and Bathinda and Dehradun. But we are predominantly in NCR region. We have got 13 hospitals there. And oncology service is the biggest single specialty across Max Healthcare. We contribute more than 25% in terms of patients and the load and the kind of work we do. And I also bring greetings from the surgical oncology community and the surgical community of India. Because India, Nepal, Pakistan, this region we have all grown, worked together, as sir, you were sharing that you started your MBBS training from India. And so likewise, we have so much in common to share, and we have to continuously build the whole region as one. Being a surgical oncologist and an opportunity to talk to surgeons at large, the thing when Dr. Shell asked me what can we talk which can inspire the people, I said every surgeon has a chance to transform oncology care in their community. For certain reasons, the patients associate cancer with surgical interventions, and surgery is a very important thing. So next 25 minutes I'll be talking about building multi-specialty oncology program requires leadership from the surgical community at large. To bring a multi-specialty program, to build that, we have to go out and help that transformation happen. Obviously, the big disclaimer is that just like each one of you here, I hope they're only surgeons and surgeons, because this is SSN, but just like you, I'm also a surgeon, so there's an element of bias, there's an element of, I would say, the intent that my belief is that probably surgeons have a bigger role, but I also understand that every person has a very big role. At the same time, I would say professions choose individuals. And what happens for our own traits, we attracted to certain professions, and that is how we become actors and writers and scientists and science surgeons and clinicians. So we also have carry certain persona with us which transforms us, and the profession also transforms us. So surgeons have certain traits which is really amazing. Now, oncology is a team sport like none other. When I say this, I actually mean it from the bottom of my heart. We talk of any coronary care, whether it is neuro, cardiac, and pulmonary or whatever, but the kind of multi-specialty requirement in oncology is, I think, unparalleled. Whether you talk of surgical, medical, radiation in terms of clinical delivery, if we talk of pathology, radiology, nuclear medicine, we talk of the extended care and multi-specialty support. So it is the teamwork which is actually a display in cancer care. And I will be talking about that building that team culture. It is not just about putting the people together. It is about putting the culture, the excitement, the enthusiasm, the positivity, the energy into the game. That is where it all begins. So that chemistry of the team happens only we build it gradually, brick by brick, because it is something which I've invested a lot, learned a lot, and still learning every day, and still bumping into problems and situations, but this is where my heart is, and this is what I believe happens. So, to preserve the spirit of the team and is essential to deliver quality care in oncology, and when Dr. Veer was sharing that how you save the person with a rod through the ear going through the chest, and ENT surgeon, thoracic surgeon, anesthesia, everybody is required. So I was reminded of the quote that to succeed, you need a lot of people. To fail, you need nobody. So whatever we do in our mission, we actually need a lot of people to collaborate, to work together, to come together, and that is what it's all about. The spirit of the team has to be preserved to deliver quality care, and all this requires is a continuous journey of mutual respect, engagement, humility, and hard work. And for surgeons, as I said, they need to own the responsibility of cancer care, because for tumors, surgeons are quite often the first point. Whether you talk of an oral lesion, whether you talk of a thyroid nodule, whether you talk of a breast lump, or a GI episode, or a gynecological episode, wherever we talk of, it is natural for patients to connect with the surgeon or link with the surgeons, except probably for the hematological malignancy and maybe lung, because it presents so late with cough. But if you look at other areas like urology and nephrology, people have, in nephrology, CKD and all, they are likely linked with the physicians, but here it is largely a surgeon's game. Now, what happened when we came to Max in 2009 and started the program with 6 people in the beginning? We thought that we have to make it into a real leadership program. In 2012, just before the ICC happened in 2013, few of us set out that we need to create a vision mission document, we need to create something, how to really make a, because in private sector, oncology was seen in a certain way. Today it's grown exponentially, almost 11, 12 years down, but at that time. So we said that our goal is to become one of the leading contributors in global war on cancer, and that will need clinical excellence, research, and obviously service. And for this we said that these are the 6 pillars which are required to build such a program. Disease management group, which is written as the first one, is nothing else but a specialized program, how to build specialty programs. The other 5, the balanced scorecard, clinical admin forum, focus on research and academics, IT technology and patient experience are supportive, but I would just dwell in next whatever time I have on disease management specialization, how that brings transformation. So, as I said, it is all about specialization. As we know how general surgery evolved into urology, into cardiac, into every specialty, likewise oncology and all areas are always into transition, always into evolution, are always into specialization and transformation. And we know so well that better outcomes in all surgeries are associated with the number of patients you do and the experience you gain. So it is well established, whether it is ovarian cancer, whether it is a Whipple surgery, whether it is a, wherever data is there, it is known by instinct and also by science that to deliver quality results in complex cases, one needs to focus in a small area and go deep dive. Also, it brings an opportunity to bring peer training, professional training, and become a center of excellence. To deliver true research and innovation, you have to really focus and go deep into it. In fact, I must confess that when sentinel node biopsy came into practice for breast cancer, I was already a breast cancer surgeon for 10 years, and I wondered why this thought never crossed me or crossed people around me, why we had to read it through a journal and and realize that, oh, it's so simple, let's put an injection, ignore node negative, node positive, and you save so many patients from doing unnecessary exit dissections. So the idea is that it happens because you're not focused on one thing, you're so thin spread out, and you're not actually looking at the patient's problem, having the conversations, building that relationship and understanding what will bring value. Likewise, we talk of VATS. When we started doing thoracic surgeries and VATS became a gold standard for esophageal surgery. At that time, already laparoscopy in gallbladder was preeminent for 15 years, and then VATS into being. And again, as I said, that these are all things when they have happened, when the bus has been moved on, then we latch onto it. We don't catch it early because we're not focused on it. If we are focused on it, we will bring transformation, we will bring change. I hope people here know that there is one center in US which does only parathyroid surgery. They do only parathyroid surgeries, and probably they do more parathyroid surgery in a year than all of us in India and Nepal do together. They do 4,000 plus surgeries in a year. It's very easily available on Google. I'm just saying that what kind of changes are possible or expertise is possible by focusing into small areas and do that. So disease management group is nothing else but about specialization and further specialization and bringing quality, creating a small team and putting them all together into one purpose, one goal to deliver the best for this patient, whether it is about breast cancer, whether it's about head and neck cancer, whether it's about lung cancer or thoracic cancer, whatever. So we created this paradigm of BMGs and subspecialties and groups. This also ensures that patients get seamless care and also ensures good communication and documentation. So this was our model of 10 DMGs as you are seeing in the topmost part of the slide, and this was supported by integrated services and completion of service and support things. So this is what we did internally, and we put it out on our website externally for everybody to know that this is how we want to function. So when people would come to me and say that you have operated on colon cancer for my so-and-so and we want to treat, I would say you can go on the website, it is on my letterhead that I want to focus on these 2 or 3 areas only and not across, and you can contact Dr. Asit and Dr. Nikhil and my colleagues who are doing a better job, and gradually build the program of specialization, and gradually less people are asking for me, they are asking for my colleagues, and they are also benefit and grown. So the framework is very helpful and it helped in a bit, but to really make it successful you have to continuously keep investing into the model and keep learning from it, to tweak it further, to improve it further, to make it better. And that is what our journey is all about. So bringing those small DM teams together, how to do it, what is the common definitions? For example, if you talk about discipline, somebody will say I come in time, somebody will say I dress very well, somebody says I communicate very well. So everybody has different definition of different things. We realize that that's also important. We have to create good opportunities for one and all and nurture each individual in the team as a part of the culture. It should be a supportive culture which supports each person's team, and the discipline to build transparency. So this is what we did for our tumor board in clinical care. So this is one of the, I would say, gold standard in oncology practice in a lot of parts of the world, MDT meetings. It is not there in cardiology and other specialty, but in oncology it has become almost like a gold standard. And where the pathologist, radiologist and the clinical team sits and discusses case by case. We made it a mandate in our system that every case has to go through tumor board, whether it is a difficult or easy case, simple case or complex case, every case has to go. And therefore we realize we can't handle all together, we make it organ based. So today, for example, on Tuesdays, we have breast and GI tumor boards happening in parallel in 2 different locations because the teams are different, and likewise. And then we realized that this is also not good enough. So we worked with GE and created a software by the name of Harmony software. So that improved the quality of tumor boards because that software puts up all the clinical data. If I can get a pointer, if you see on this side, it takes all the data from HIS, LIMS, from CPRS, from different sections in the IT platforms and puts it on a one pager. I'll show that page also, everything together. It is capable of, So this is what it improves the quality of tumor boards. So initially when we were collecting all the files and going through the files, it was very cumbersome and a lot of data was lost and these were not genuine tumor boards. So my question and discussion with GE was that how can we make a tumor board where each case is successful in 60 seconds? And that is what I built by putting this Harmony software on a single shot. It all comes on the... So what it started doing was, it became a repository for outside information also. Patients carried a lot of files with them. In fact, 30% of patients come with outside one intervention. You have lost that data. 80% of patients have some investigation done outside before they land up in a clinic. So all this data started getting captured and we could get it on the Harmony software. It also started helping structuring the data properly because it had different segments the software picked up and to help us in doing that. And then the availability of this app on your mobile. This app is now available on mobiles. So we can actually put in data. Suppose a surgeon is not able to come to the tumor board, he can put in his opinion on the dashboard which can be shared at the time of tumor board discussion. And certain niche specialties like musculoskeletal, pediatric, urology, hematology, where our teams were small in that respective tumor board in location, we could connect across centers and have a larger group for group discussions. So that also helped a lot. And one of the side products or byproducts of this was it expedited the quality of discharge summaries and the quick discharge summaries because all the data was on one platform. So that was one side effect which was not understood earlier. So this is how it looks. I know it's very congested. So this is the dashboard of the, this is the screen on the right side, which is showing us that how all history examination findings appear on one screen, and then you can discuss case by case and enter that. It also marks the attendance. So this was a very good one intervention making a difference. Then we realized that there should be one communication how we want to people to find direction in their lives. And we said that I bumped upon this very good model of Patrick Lencioni, which is a TED talk also and a lot of material on this on YouTube. It's about the ideal team player. And they said there are three components: humility, hunger, and excellence, which is important for a member to understand how you're contributing to the team. So humility is about collaboration within the team. Hunger is about building the organization beyond borders and beyond team, and excellence in whatever you do. So as we commit to all these three things, we create that ecosystem. So likewise, when we talk to our colleagues, we work with them, we build that and make it happen. And around this, we created a balanced scorecard which focuses not just on patient footfall, but other things also, which includes the 360 feedback from our colleagues. We did this exercise twice with some success. These are very difficult things, very difficult journey, not easy to execute, but we have been able to do this to some extent. We also created a platform where the contribution done through publications, through efforts like participating in CMEs, organizing events, because everything needs time and effort. How do we rate that and put that into a scorecard where people are recognized for their work? And we could equally create that, and now we have this model. Then we went on to a program on OKR, Objectives and Key Results. It's a very good, again, a book and a talk by Andy Grove, who created this for, I think, Ericsson or something, where he created a model that if you have an objective, what are the things you have to focus on? Right now, what we do is focus on the objective. We want to achieve success by having more cases, or we want to focus on network or this. It says that, for example, if you take a New Year resolution that I want to lose weight, that the key results are not to focus weight, but to gym, exercise twice a week, reducing or increasing walks, and controlling your diet. Likewise, whether it is about anything, about publication, without a position in your Society for Surgeons in Nepal, to become a president, you have to first become an EC, you have to make that effort, you have to make your network and contribute in that role, and people recognize your contribution and gradually move into it. Likewise, whether you want to publish, you want to learn a new skill. When robotic surgery came into being, it doesn't come naturally to all of us. So only those who invested big time grew into that. And likewise to build practice and patient base. So these are the objectives for which we created workshops that how people can focus on key areas and provided support to them, whether it's about collecting data, setting a plan, whatever, we could do that and create a team. So to this OKR, it is good for individuals. But when you put a team together, this is not good enough. And we bumped into other things. So it's also celebrated that you gradually come across ideas and people, and at the right time, right thing starts clicking. So we came across this a 4DX model which adds 2 more steps to objectives and key results. And those 2 steps are creating a accountability model where each person is having a regular rigor of meetings, and then creating a cadence of accountability. And we created a software for this also. I will share that. So this is the focus of the team, what we are trying to do all together, what will lead to this outcome, and then create a model where we create a scorecard. And we have got that scorecard, I will share that with you. So this is just an example that how we create a widely important goal and create actions linked with that. So this is the software, the 4DX software which we have today at Max. And this is a calendar where we put in our activities, which comes into a table form, as you see in the bottom right corner. And this helps in every week review, that what are we doing right, what is not working, what can be tweaked. So all these ideas have happened with a lot of handling discussions. Some are in partly execution, some have not worked so well, some we are still pushing, trying to help people, because at the heart we are all doctors, invested more into time into that space. But these are all soft things which make it all possible to be more effective, to be more useful, to be more constructive as a team, as an institution builder. And that is what we try to do. And we also realize that putting all these models is an important thing. So practically what we see in day to day is skill and knowledge of the person interaction. But there are a lot of factors underlying which bring a great change. So in last year we started one more program with the team which focused on 5 things. 3 are listed here. The one was a growth mindset, that is that how to help people through workshops that think positively. Whatever things will not work the way you want it to work, but think positively. How to handle difficult conversations. So I read this somewhere that if you're not moving forward in life, probably some difficult conversation is holding you back. So whether it is home, whether it is in a conference, whether it is in a departmental meeting, wherever you are, difficult conversations is essential and will bound to happen. And we all need training for that. And productivity and time management are other things. So this is just to emphasize that in a growth mindset, people think that feedback is invaluable. That is where value comes from learning. And whereas in the fixed mindset, the feedback is taken as a negative thing. This person is not understanding me, I know the best kind of thing. Likewise, when you do a mistake, you feel that okay, you can come out of it, you can learn how to get better. And sometimes people feel that I want to avoid a mistake, don't get into this mess again, don't pull a rod out again, or don't get into this surgery again because you had a misfortune or an outcome poor and all that. So these things bring a difference. Likewise, handling difficult conversations, whenever conversations, so it has 3 pillars. Whenever there are contrary views on an important subject which is of value to both the stakeholders and emotions are high, it's a difficult conversation. It can happen in a transaction, whether you're selling a property or you're having a discussion with your son what subject to choose or whatever. And so what happens typically, we tend to avoid this conversation, delay the decision. So one has to face it and nail down the purpose of the conference, of the meeting. That we want to have a positive result. We want to come out together successful. It's not about one-upmanship or trying to build it. And be willing to listen to the contrary view. Take a step back. You are thinking right, but the other person is thinking brighter and may contribute together to a bigger purpose. So that kind of a thing, we do these workshops with our colleagues, and it helps in understanding discussion and probably helps in bringing more harmony than otherwise. Because otherwise, to have professionals working together in large numbers is actually a challenge, because contrary views are very common. Whether it is a tumor board, whether it is a medical surgical talk, whichever talk, it's difficult to accept that why we can't do surgery first or why chemo first. Whatever the guidelines say, still there will be more views and more information. So unless you build this culture of handling this, strengthening these soft skills, transformation doesn't happen. It becomes a combative thing, one-upmanship all the time, and gets worse with time. So we are trying to fix this by doing all this and helping this go through. While we are doing all this, and that is what patient experiences in a big way, but I still feel that most of us and most of our institutions say that we are patient-centric, but we do not know actually how to measure patient-centricity. And this is another thing which I have tried to work with colleagues to find out what is that index, and also a clinical audit culture, which is very crucial, very important, quite widely accepted in the Western world, and still we are trying to fix that. So this is what is the patient centricity index. Based on the patient's inputs, every employee, every doctor, every person should know what is my PCI score, how patients rate me, and that is based on not clinical outcomes, but punctuality, communication, empathy, documentation, and display of teamwork. What happens, I go around, I tell something to the patient, 2 hours later, one of my senior colleagues goes around and tells something, or just the opposite. And this happens every day. So these are things which confuse the patient about the team or the whole messaging. And when this happens in an ICU or when they're in a theater, then it's a very big issue. So how do we fix all this? Unless we create a roadmap that we keep fixing it, every time this happens, you know that there's something we can do to make it better. Only then we can fix it. And that is what we have tried to do in making this possible. So if I focus on all these things, we need to build one more pillar very essentially in all our organizations and institutions and departments, and that is the culture of audit. And that is very basic and very essential. I got a small video of exactly 1 minute 18 seconds which I wanted to share. This is by P. Raghuram. He's a thought leader and he's not a doctor. He has given an example of
cross-verify commands between the flight crew to ensure that there is no miscommunication. And while aircraft manufacturers do their best to ensure flight safety and redundancy,
volume.
There is a
Mic. Acha, mic here. Okay, sorry.
confirmatory checklists, cross-verify commands between the flight crew to ensure that there is no miscommunication. And while aircraft manufacturers do their best to ensure flight safety and redundancies of critical systems, there is a tacit humility in admitting that despite all of this, there could be a crash, and even in failure, there would be learning. And that is why a black box is installed in every plane. There is thus psychological safety in a culture which makes it clear that even sophisticated technology could fail or seasoned pilots could be wrong, and it's okay to question what seems to be an incorrect instruction. Compare this with, say, the healthcare industry, where doctors are treated as prima donnas, and it's usually sacrilege for a junior nurse to question the instruction of a senior doctor. Despite clear indication of doctor errors, fatalities are usually attributed to statistical failure rate for the procedures. Doctors purportedly never commit errors, so there's no question of near-miss reports being filed. Beyond informal conversations, there is no structured learning from those mistakes. That is probably why over 200,000 deaths are estimated every year in the US alone due to medical errors.
So I brought this because this is something I displayed in my team also, and I bumped into this. And I think it is so essential to create a culture of audit and learning, because unless you have that, we all only talk about mistakes and only patchy learnings happen. The real learning of the institute at the institution level is very rare. So I would say that we need this, we need all this and probably much more to bring transformation in cancer care, to bring transformation in any department, to bring transformation in any team or any culture. And it's an onward journey. It's all the time we are learning and evolving. And I would say quite essential to have a shared goal, a framework to strengthen collaboration and common definitions and mutual respect. I think we need to really go on and focus on the patient and make sure that every experience, every clinical outcome stands the test of time. So, friends, it is something which I've shared, what we have tried to build. We are still trying to build. We are not nowhere close of what we want to be, but we are trying every day. And I would say that what we could do tomorrow morning to make our lives better, probably just start strengthen conversations within the department, within the teams, create tumor boards, create culture of discussions, and make small plans and a bottoms-up approach by discussion. When we went out in our offsite, we created the first plan. It was only about 20 people in that plan. And now I know that it seems top-down, but actually it was bottom-up, and still the constant discussion keeps happening, and that is what has helped us in making sure that there's an onward journey. And keep focus on the essential things. Nobody is born with all the ideas. No DNA is carrying all the tricks. It is a skill, it's a learning art, which we have to continuously absorb and retain, and whatever we keep doing the better. So it will take time, it will take a lot of time, but still it is a journey worth living, and I really enjoyed so far, and I hope that few of this will make sense for you also. So thank you very much. Thank you for all your time. Thank you.
following our discussion, we planned for other options were also still available there, but due to the situation of the patient, resource, and considering all the settings, it was not possible. So we planned for the cross leg fascial tendons to reverse sural artery flap from the left leg. The flap was designed, and it was a long flap, so we planned for. It was designed in the left leg, and it was delayed for 2 settings, so that we can get a good length of the flap. So on the 3rd setting, you can see just see there is a cross leg flap raised, and it has been placed into the affected limb with the skin graft in the donor side. And very important part of the cross leg limb is we have to always use the consider the immobilization. It was done with the cross leg external fixators, as we can see in the picture B. This is a post-operative day 5 in the picture B, and the F is after detachment of the flap. So this is the case profile that we have done in our center. Coming to the discussion, cross leg flap can still materialize when idle or in those situations. So to conclude, in context where the microvascular flaps is not feasible or in the resource constrained environment, the cross leg flap remains an
तुम्ही तर मग
Chairpersons, thank you.
Good afternoon. I think probably the audience might be coming up. So I'll call upon the first presenter, Mr. Dr. Ranveer Singh. Highway disaster in laparoscopic cholecystectomy, how to prevent it. Dr. Singh, the floor is yours.
I guess we have been here talking about so many disasters in different advanced surgeries. Let's talk on the disasters in the most common surgery. I guess every general surgeon is performing day in and day out. That's the laparoscopic cholecystectomy. I bring greetings from my country, India, and my hospital, Oswal Cancer Hospital, and from the SAGES Safe Cholecystectomy Task Force. So since 1995, we've been seeing there are a storm of bile duct injuries occurring around the world, in and around the globe, and which is a concern for the surgeons. But in a very common operation which is being performed by all the general surgeons, that's the cholecystectomy. Laparoscopic cholecystectomy is unique and the most common laparoscopic surgery being performed by the general surgeons all over the world, and places the patient potentially at significant risk of bile duct injuries. This is around 0.8%, which is a Western data. In our country, we suspect it to be more than this, a lot more than this probably. So no surgeon is immune for injuring the bile duct injuries. We can injure the bile duct and not even recognize it. 25 years later, it is still happening. Surgery cannot occur without complications, and we must avoid them, recognize them, and treat them competently. So the most major disasters which occurs because the surgeon, they fall into an error trap. So what is an error trap? Error trap is a certain odd circumstances like the inflammation, the anomalous anatomy, and the difficult pathology in itself or in combination, which deceives the surgeon and which leads to disaster. Disasters: how, when, where, and why. The disasters which commonly we have found is because of misidentification, that is the biliary inflammatory fusion, that is, and the human psychological factors, the technical mistakes, and the local factors. Misidentification, this is a very important slide. Misidentification is, there is two schools of thoughts. One is Professor Strasberg's view. He says it's a method-related problem. The infundibulary view method of ductal identification is the error trap. That is the classical biliary inflammatory fusion, when the common bile duct and the cystic duct gets fused up because of inflammation. And what the surgeon, the visual deception is that the surgeon thinks it's the common duct, this is a cystic duct, but it comes to be a common bile duct, and he lands up into the classical bile duct injury. This is a video from Professor Michael Brandt. This is a classical bile duct injury happening in a patient with biliary inflammatory fusion. His school of thought is the infundibular method. So you will see the surgeon, he is operating and not even recognizing, not even doing a diagnostic laparoscopy, not the most important thing, not recognizing the landmarks. The landmarks are the cystic lymph node, the duodenum, the roggeral sulcus, and the first structure he identifies, he thinks it to be the cystic duct, and he is clipping without even dissecting the calyx triangle. And we have gone in much beyond the calyx to a hepatocystic triangle, and you can see a bigger clip, 400 clip, and still there is still this tissue is left. So after clipping, he finds the artery, and he subsequently continues. And now this is really pathetic. In this terminology, you can see the common hepatic duct has been transected. The surgeon does not stop. He doesn't recognize that he has already cut the common bile duct, and now the common hepatic duct is also cut, and he still continues, and then he recognizes that he has already cut the common hepatic duct. So this is basically it's the infundibular view method, the inflammation causing the fusion of the cystic duct and the common bile duct. Surgeons' feedback after having done bile duct injuries, this is a US experience, they say that 13% says that there was boldness, speed, impatient, as we see here. 50% conversion should have been done early, but they didn't do. Majority of surgeons say, 70% say they did not have an open experience and relied on laparoscopy. 93.9% said misidentification and imprecise dissection and poor visualization of their anatomical structures. Easy gallbladders, more injuries. 80% no risk factors, still bile duct injury occurred. So, Dr. Strasberg says inflammatory. Then why does injuries occur in simple cholecystectomy? So there is another school of thought, another viewpoint by Way, Hughes et al. They say that human factors, 50% of the bile duct injuries occurred in simple cholecystectomy, no inflammation. When they reviewed the videos, they said adequate skill was there was minimal blood loss, the section was okay, but the experience of the surgeon was good, but fault was at the action level. The surgeon was disoriented, and he actually started, the action point was at the wrong level. What the misinterpretation thought, he thought that it could be cystic duct, and he started to dissect. That is known as the functional fixity. To understand this human psychological factor, we have to know the sequence of cholecystectomy. So this is a video I'm going to show. This is a simple cholecystectomy. You see no no infundibular traction. The first structure he sees, only one hand working. The surgeon just clipping and clipping. You can see he's clipped, already put in 3 clips, and there is another clip going in, and he thinks the first structure he is going to be is the cystic duct. And you see he has cut the structure after putting in 1, 2, 3 clips, and you see there are 2 lumens. So simple cholecystectomies also, bile duct injuries are occurred. So misperception, human psychological factors, inflammatory fusion, 2 schools of thoughts. Another school of anomalous anatomy. You can see in this picture, this is my picture, one of my patients you can see. This is an aberrant, this is a aberrant right hepatic duct entering into the cystic duct. So we have to dissect it like this, that anomalous anatomy to this, we have to clip it above this, so that this is probably the cystic duct, this is the cystic duct, and this is the right aberrant hepatic duct entering into the cystic duct. This is the anomalous anatomy we encounter, so you have to be very careful, and this is because when we do complete and good dissection and thorough dissection. Complex, unpredictable anatomy. It is difficult to know what is normal and what is abnormal. What is abnormal is normal for that individual. So the anatomy is relevant to the cholecystectomy, is not limited to the calyx triangle. It has made much beyond the calyx to the hepatocystic triangle. Professor Hunter says, once the anatomical confusion has led the surgeon astray, injuries occurred in predicted manner, no matter who is doing it. Next comes the local factors, the acute cholecystitis, empyema gallbladders, gangrenes, chronic cholecystitis, Mirzi syndrome. These are the risk factors to these injuries. Technical reasons, these are improper putting in trocars, using thermal injuries, using too much of cautery, then teasing and pulling with hook, poor resistance, stenting injuries, deep dissection to liver bed, and excessive dissection near the common bile duct. So, injuries beyond the hepatocystic triangle. So, another video, you can see the cystic duct and the arteries being defined, clearly cut. They say that 2 and 2 structures have been found. The hepatocystic triangle has been cleared, but on dissecting the lower 1/3, you can see something has happened here. Something has happened here. The surgeon does not recognize, he's still using a hook and he continues, but intraoperatively after putting, he sees that there is a bile. So this is basically the injury to the duct of Luschka, which is gone, which we see it grooving across the liver bed. This is much beyond the calyx triangle, still a minor bile duct injury, but bile duct injury has occurred beyond the calyx triangle. Now something really scary. So there's another video for you. So again, a critical view, what we've been discussing, making 2 windows is of Chevenon. He has also made 2 windows. He has made a window between the duct and the artery. He's clipped the artery, and now, as commonly performed in Western countries, it's their normal routine of doing an IOC. They did an IOC and they confirmed it to be a cystic duct. But 2 and only 2 structures, clipped and cut, does not mean achieving critical view of safety. So now he uses a hook and starts dissecting. And you see something has happened here. The right hepatic artery is been cauterized and it's occurred. You can see the surgeon's experience. He is so experienced that he's put in a bulldog and he's suturing the right hepatic artery. Means there is no problem in his expertise, no problem in his working, it is the thought process. So, the error trap 2, this is the error trap 1. Fundus first cholecystectomy in case of severe inflamed and chronic gallbladders. Never go top down. This is the portal pedicle, the cystic plate gets shortened up, and you finally land up into injuries leading to portal pedicle hematomas and major vascular injuries. Do not attempt fundus first method laparoscopically in gross inflammation. It's an error trap, very cautious approach, and only by the experienced surgeons. Now, how do we prevent these disasters in cholecystectomy? It is said that adverse events in surgery is 3%, 54% are preventable. Not to go with the belief that it can happen and will happen, no. After effects of bile duct injuries are so much, best is to avoid them. I am of the firm belief, if followed the laid down principles of surgery during cholecystectomy, yes, it can be prevented significantly. Surgeon and the dissection is the key factor. This is basically the surgeon's experience. The past success of your surgeries is no guarantee of your future safety, no overconfidence, no underestimation of the risk. Experience does not guarantee expertise, and you cannot become expert without experience. Superior judgment comes through constant learning and experience. Culture of safety and pursuit of excellence should go hand in hand. Human psychological factors, this is disorientation, the visual perceptual illusions, the functional fixity, the false hypothesis, these all lead to misidentification. Therefore, tackling this misidentification factors and finding a correct method of identification of the cystic structures which safeguards the vascular ductal structures coursing in the hepatocystic triangle is our aim. And Professor Strasberg in 1995 coined an approach of surgical dissection to way forward for a reliable method of ductal identification based on the concept of the fundus first method of conventional cholecystectomy. Ensuring safety from bile duct injury is what is the critical view of safety. Critical view of safety, as said, is not a method of ductal identification. It is carved out of a specific prerequisite dissection already in place. The three attributes of the critical view, I guess Dr. Bickle has already told, the three attributes, they have to be put in after the dissection is already in place. Hence, CVS method is only applicable when dissection is in place. I have a video. This is a video 2 days back before coming to, I got to encounter this patient. This is a patient already done a diagnostic laparoscopic by a surgeon and referred, put in a scope and taken out the scope and referred to me. So when I entered, this was the situation inside. Everything, momentum, the tough adhesions due to acute attack was there. So we did a blunt dissection with a 0-degree telescope. No second trocar. Then we inserted the trocar. We normally use gauze piece, and this is basically no hi-fi energy sources, simple bipolar cutter. This is a new instrument, I've been using it, and it's been working really well. So you can see it's normal gentle dissection with gauze piece and dissection starting from the medial to the lateral and identification of the gallbladder first and very close to the liver surface, and slowly and steadily just removing the omentum which is getting entrapped onto the gallbladder so that we can find the gallbladder and do adhesiolysis. Bipolar cautery is one of the most and a wonderful energy source, less lateral transmission and less damage to the tissue. So low cautery, and this is a bipolar cutter, so it does majority of the job. And this is probably after having done, so we go down after dissecting all this omentum fat. This was also stuck up, so slowly and steadily going through medially and started dissecting and clearing the hepatocystic triangle so that we can see and identify our structures. So sometimes we have to be a little bit forceful in removing. So this is, you can see, this is the plane we have to introduce. Now we will identified the infundibulum and we have started the posterior dissection first. Posterior dissection, you can see this is the dissector we have been using. This is a special dissector we have designed. It's a blunt dissector we formally do so that it is easy for us to dissect. So posterior dissection first, as told. Posterior dissection, making closer way, making a window from posteriorly, and then we go anteriorly. And slow and gently dissecting very close to the gallbladder. And you can see, and slowly and gently, this smaller oozes and bleeding, you don't have to be you don't be scared. These are just put in a small gauze piece, just put in, don't be in hurry, don't use cautery, just slow lateral dissection. Now we are dissecting the anteriorly, the anterior peritoneum is lifted, and you see that we have identified that the common bile duct and the common hepatic duct is attached to this gallbladder due to, so we are using this bipolar cutter. This is as I have told, it has lateral transmission is very less, so it is very easy, slow energy bipolar cautery, and then we go to the posteriorly, from posterior then anterior, and from one side laterally to the medially, and we have started dissecting. Slowly and dissecting we have found the second, we have dissected the artery and the duct. So, two and only two structures. This is the first attribute. Hepatocystic triangle, clear of the fat and the fibrous tissue, done, but lower 1/3 of the gallbladder has still not been lifted. We are doing that. So all the three attributes have to be achieved before we actually clip these structures. So after having confirmed the two and getting a doublet picture, that is the duct and the artery first, and then we get a complete single structure attached to the gallbladder. This is typically like a visual cholangiography we get. Two and only two structures, 1/3 lifted, and the duct and the artery. So you see this is the common bile duct, the common hepatic duct, and the artery, and the duct we have dissected. What do we get by achieving critical view of safety? We see when 2 and 2 structures, we ensure all the structure is correct. Second, we when delineate, the second part is that all the common bile duct, common hepatic duct, right hepatic duct, they are in this hepatocystic triangle. Third part is lifted to prevent these minor injuries which we have seen, like the duct of Luschka. This is very important. How do we assess that CVS criteria are met? This is not CVS. Please be careful. Making 2 windows is not CVS. It is Nissen in his 1108 patient have reported that 80% of the reported in the OT notes said that 80% patients achieved CVS, but actually when they were reviewed only 10.8% CVS was achieved. So it is emphasized that where CVS is followed, there will be no bile duct injuries, and where the bile duct injuries occur, there would be no CVS. Breach in the CVS components. Is it safe to proceed? To be assessed by the operating team, which component is deficient, or use an intraoperative cholangiography, laparoscopic ultrasound, and if a team is quite certain of all the structures, we can still go ahead even if we have lifted 1 centimeter of the cystic plate. The alternate approach is, that's the bailout, is the subtotal fenestrating and the subtotal reconstituting, which all have been discussed by my colleague surgeon. What does culture of safety in cholecystectomy means? COSIC. It means putting safety first, using a reliable method of ductal identification, that is the critical view of safety, recognizing when the dissection is approaching the zone of danger, halt the dissection, getting help from the colleague. I guess this is the most important thing when there is difficulty, sometimes finishing the operation by a safer method other than cholecystectomy. If you breach this process, you are heading towards disaster. Does cholangiography safeguard from bile duct injury? Another beautiful video. So, identified the cystic duct as the surgeon thought that the first structure he thinks is the cystic duct. He's made 2 windows, he's identified the cystic artery as well, and now he starts clipping. He's clipped the artery, and as in Western countries, it's a routine to do an IOC. They did an IOC, and after doing an IOC, they found that the catheter was in the common bile duct. So this is the intraoperative cholangiography, IOC done, and this is the finding. So IOC is helpful, and then he goes back to his normal position. So now you see how he identified the cystic lymph node. So why do we need an IOC? Stick to the basic anatomical landmarks: roviral sulcus, lymph node, duodenum. First do these, then you see. And these, after doing and such an injury, there was a minor injury, so he sutured the cut. That is the minor injury which has happened because of doing an IUC. This is a new thing into picture. We've been started using ICG in difficult cholecystectomies. It has advantage, gives continuous biliary mapping, but limitations are there as well in difficult situation and in obese patients. Subtotal cholecystectomy, we already discussed in thorough detail. Avoiding disasters in difficult situation, do a cholangiogram. Convert to an open procedure, get help from a colleague. Do a laparoscopic or an open cholecystostomy or a partial or a subtotal cholecystectomy. Stop and retrieve. Do not do top down in face of acute inflammation. Even finding a difficult situation, hold it for later for a successful surgery. Can disasters be prevented by conversion? Yes, with cautious. There will be no pop-ups on your screen and signals on the monitor to stop. Does surgeon experience prevent bile duct injury? Yes. Surgeon is the key factor. Is fundus first method safe? Is safe to prevent bile duct injury? Yes, to some extent, but we have to be very cautious, and we can add on some IOCs or the ICG or the laparoscopic ultrasound to whoever if there is some doubt. It should always be attempted by an experienced surgeon, as stated by Professor Strasberg. Subtotal and partial, they have a definite role. This is our data. We have done on 2,300 surgeries, and this is published in the Journal of Minimum Access Surgery. This is our Journal of the Indian Association of Gastroenterologists, and we had only one minor bile duct injury. That was the duct of Lushka, which we've seen. That's one of our team members did. I conclude, no surgeon is immune from experiencing bile duct injuries. Misidentification of the biliary ducts and human psychological factors, they contribute significantly leading to bile duct injuries. CBS is such a surgical approach that signals, which makes you think, stop and do alternate safe approaches. It replicates a proven fundus first method of safety from bile duct injuries. Breaching critical view of safety approach will result in all sorts of vasculoductal injuries, leading the patient to biliary cripple. Therefore, landing safely, the surgeon is to keep in mind other alternative safe approaches rather than getting crashed. There is no place of overweening self-confidence, pride and arrogance in surgery. The pilot, the surgeon, must feel the pain of the passengers, his patients. Above all, do not harm. Safety remains the final frontier. This has already been stated. Safe Cholecystectomy Task Force has launched a program, that's the bdi.org. You can step on to the online and search on this. There are so many modules, and this is an excellent paper we have just published. It's a review article on the critical view of safety and feasibility in the annals of the laparoendoscopic surgery. Thank you.
You know, in Kathmandu in 1993, we had a surgical conference, and Professor Udvadia was here.
Yes.
And at that time, we had only experience of a couple of hundred cases. And obviously, common bile duct injury is a nightmare for any surgeon.
Absolutely.
And he showed us a picture which I got from him only just before he died. And it was shown as a gallbladder and surgeons sticking to the gallbladder.
Absolutely.
You know, just embracing the gallbladder, which means that, and I think it's true to date, that close to the gallbladder.
Hug the gallbladder.
Right.
His saying is
that's
hug the
right.
gallbladder.
You know, I still have that 30 years old picture with me. The other thing is that, mind you, fundus first method sometimes you can injure the common hepatic duct.
Absolutely.
Remember. So these are the two comments I wanted to make.
Wonderful, sir. It is the same. We've been associated with Professor Udvadia sir since long. He's the founder, and my father has been one of the founders of the IAGS. And there's a typical picture what you said. Hug the gallbladder. There's another thing, elephant's hump. You have to see the elephant's hump before you clip the duct. And this is his saying, and probably we all focus on these things that we have to close to the gallbladder. But it doesn't mean that we have to be on the gallbladder. We have to dissect the hepatocystic triangle. And this is, the concepts change. Initially, the fundus first method was done. Dr. Professor Strasberg also writes in one of his articles that fundus first method is the right procedure. It is not a wrong procedure, but we have to be careful because we don't know about the medial side. It should be like typically attached to the gallbladder, and you get that elephant's hump. Only one and one structure. You get a typical elephant's hump, then you can clip it. Doesn't matter. But if you don't dissect it with the first structure you will get, then you will end up this problem. One bile duct injury, that patient will remember you your lifetime. Even if you've done 1,000 good, one patient will keep on, will be behind your life all day. I guess this should not happen with all of us. This is a very common procedure. All general surgeons, they are practicing surgeons, there are PGs who are training. I guess this is the first procedure I guess every surgeon is doing. Probably you are not doing distal pancreatectomy, or you are not doing hernias, or you are not doing AWRs, but you are surely doing cholecystectomy. I guess this is our message: do not do no harm.
Thank you.
Prevent by that. Thank you.
Especially the patient individuals.
Meetings from a new surgery block. We have a dedicated general surgery block consisting of 200 beds and 12 operating theatres, only dedicated to general surgical practice. Today I will be giving a talk on laparoscopic fundoplication, the tips and tricks. So the most important tip while doing a fundoplication is very careful patient selection. These patients should be thoroughly investigated. You should not miss the manometry, as we had discussions today. A lot of people were asking whether we should do a fundoplication without a manometer. We should not do a fundoplication without a manometer. Other tip is that hiatus hernias is not synonymous with GRD. Although GRD is most commonly seen with type 1 sliding hernias, but it's not the other way around. And the most important thing is that while deciding the surgery, it should be a shared decision between the patient and the surgeon, where we tell them the pros and cons of each of the various techniques of fundoplication that we do. So indications as we all know, are for GRD, LAC, esophagitis, patients with Barrett's, failed medical management, and problems with medication, lifelong medications, need for any side effects due to the proton pump inhibitors. And apart from that, fundoplications are done for hiatus hernias without GRD and in cases of achalasia cardia as an anti-reflux procedure. So in the workup, the first is the upper GI endoscopy. This is very important to rule out other diagnosis, and most patients who come with reflux, we would have had an upper GI endoscopy. It helps you grade the esophagitis based on the Los Angeles classification and rules out it also gives you an idea of how the mucosa looks and rules out presence of any adenocarcinomas or Barrett's esophagus in these patients. Barium swallow is another important investigation. This is usually done under fluoroscopy guidance, and it helps to demonstrate reflux. And it also helps you in locating the G junction with respect to the crura. And the third important thing is sometimes it gives you indirect evidence of motility disorders, where when there are tertiary contractions, the esophageal mucosa becomes irregular on barium. Third is the most important is the manometry. Manometry will help. While doing a manometry, it's going to tell you whether this patient has any associated motility disorders. Patients with GRD often have ineffective esophageal motility linked to it. And it also helps you rule out other esophageal motility disorders such as achalasia. Another important role of the manometry is that it helps you put the pH probe when you are doing a 24-hour pH study. So 24-hour pH studies are the gold standard and demonstrates reflux, acidic reflux, which is most important to be documented before we go ahead with the fundoplication. So the Lyon consensus has recently been updated to 2.0. It says that on endoscopy, grade CD, esophagitis, presence of Barrett's. On 24-hour pH, you see acid exposure times of greater than 6% and total episodes of more than 80. And on high resolution manometry, it will help you tailor the fundoplication to be done in the patient. Adjuncts such as chest X-ray and CT scans can be used, and X-rays usually show retrocardiac shadows of hiatus hernias, and CT scans are usually required in settings where there is no reflux, but patient has pain and these hiatus hernias come to us with obstructions. So once this evaluation is done, what are the options? The options of fundoplications available are the complete, which is the Nissen's, which is the most commonly done fundoplication in patients with GRD. Apart from that, with the partial fundoplication, the anterior doors or the posterior toupet. And we are doing the angle of his accentuation in patients with achalasia cardia, where we just hitch the fundus and make the angle of his acute, because in patients with achalasia, usually the rest of the anatomy is intact. And the other observation, which is mostly historical, is the Belsey Mark IV, which was done to the transthoracic root. So, how to decide this surgery? Earlier, Nissen fundoplication was done standard, but nowadays a lot of studies have come which is showing toupet to be equivalent to Nissen's. However, these decisions should be taken based on the investigative reports, and the pros and cons of each of these surgeries should be discussed with the patients. So if a patient wants reflux improvement but does not want dysphagia at all, he doesn't want a new problem, in those patients maybe we go ahead with the partial fundoplication. A patient who is so troubled with reflux and says, I'm okay if I have some sort of dysphagia or gas belching, in those cases we can plan for the partial fundoplications. So the Lotus trial was published in 2008. It standardized the steps of doing a fundoplication. where the principles were that first you open the phreno ligament and approach the hiatus. They suggested to preserve the vega, including the hepatic branch. Then complete dissection of both the pleuras and a circumferential dissection of the esophagus, that is most important, to achieve an intra-abdominal length of 3 centimeters or above the esophagus. A posterior pleural closure, short gastric division, which is now again under a lot of controversy. The recent SAGES update has told that this again should be discussed with the patient prior to performing the surgery. We'll talk about this in the later slide. And a short loose wrap. It should be around 2 centimeters and it should be floppy. And the use of bougie is depending upon the surgeon's experience. However, we often prefer to use the bougie while doing the fundoplication. So patient position, we use either a modified lithotomy or a French position for the patient, and we use the standard 5 ports. There is a 12 mm supraumbilical port, 2 pararectus ports, and 1 in the anterior axillary line. And the 5th port is used for a Nathanson retractor to retract the liver. So the first thing is on initial entry, there are various types of hiatal hernias that we encounter. So in this we see a small hiatus hernia, and initial phase we divide the pars flaccida, preserving the hepatic branch. Sometimes along with the hepatic branch there is an aberrant right hepatic artery which has the tendency to get injured. So one should try to preserve these structures, and then we identify the pleura and start the dissection either from left to right. Some surgeons prefer the right to left approach. This is a larger hernia where we see a significant amount of the stomach going inside. An even larger hernia, when we see these inside, then we have to think that we may require a mesh in this condition. Then in emergency, we see these kind of patients who come with obstruction. Most of the stomach, as you can see, is inside the hiatus. And then we can see the pylorus and the duodenum, which is obstructed because of acute angulation or twisting of the stomach. So initial entry will give you an idea of how to proceed, what will be the steps that are required in addition to the standardized steps, especially with the use of mesh, how much to mobilize, requirement of division of the short gastrics or not. So once we reach the pleura, it's important to leave the peritoneum over the pleura. And we start the dissection. In this we can see that it's very important to enter the right plane, and this is probably the most important step of surgery, to identify the sac and to enter this fibrofatty plane, which is mostly avascular. Once we enter here, most of the surgery can be performed just by blood dissection. And it's also important that we don't go very close to the esophagus, because there is the potential of injury to the anterior vagus nerve, which lies right over the abdomen, as you can see in this video. Mediastinal dissection is usually progressed as far as possible. And while doing this, one must be careful. On either sides lies the pleura. And while using energy, sometimes there is potential to open the pleura. And then the anesthetist will start troubling you, saying that there is increased pressure, put in an ICD. In most cases, you do not require an ICD. All you need to do is just put in a suction, take a prosthetic suture along the pleura, while sucking, withdraw and tighten the suture. And usually, in most cases, that works well enough. Once the anterior dissection is done, one progresses towards the inferior dissection or the posterior dissection, where the esophagus is lifted, and we try to create a retropleural window. And while doing this, we need to identify that both the pleuras converge, and throughout this dissection, one must ensure that the peritoneum remains over the pleura. While doing posterior dissection, again, it's very important to get into the right plane, because here we can have the potential to injure the posterior vagus. And also right below it lies the aorta, which you will be able to see, the descending thoracic aorta, which will be seen pulsating, as you can see there. And this dissection is progressed, and it's described to go all the way up to the inferior pulmonary vein. But the circumferential esophageal mobilization depends more on getting an intra-abdominal length of esophagus, a good length of approximately 3 centimeters. So once the hiatal dissection is completed in the anterior and posterior part, there are small fibers lying from the left pleura, which are again dissected. And the through the retrocrural window, one was put in a sling. This helps in retracting the stomach and the esophagus down. Here through the retrocrural window, we usually use a umbilical tape or a sling. And this helps you bring down, gives a lot of help while giving traction to the esophagus. As we can see, a good esophageal mobilization has been achieved. We can see the convergence of the pleura in this. The last few fibers of the crust attaching with the esophagus is removed. And here we can see how we have been able to create a 3 centimeter intra-abdominal length of esophagus. Once this is done, comes the next part, which is the short gastric mobilization. Now, this is a controversial issue. Division of short gastrics have been thought to lead to gastric denervation, and a lot of patients have gastric belching or gas bloat symptoms in the post-operative period. So it has been suggested that it may be avoided in patients undergoing fundoplication. But again, this has to be discussed, and it also depends a lot upon the anatomy of the patient. So in this video, we can see how without short gastric mobilization, we are able to bring in the fundus in a significant proportion of patients. But in the other video, you can see how the spleen is so close to the fundus, and giving exceeding traction leads to torrential bleeding in these patients, and it becomes a mess while doing this surgery. So in these cases, the short gastric division becomes mandatory. So these are the anatomical reasons of why short gastric mobilization may be necessary in some patients. Some surgeons say, okay, don't divide the short gastrics, just do a partial fundoplication. But again, it's not well established that a partial fundoplication does well in all the patients.
I think so. You have got a minute.
Sorry?
Just a minute.
A minute. Yeah, I'll finish quickly. So next step is the shoeshine maneuver. This maneuver is done to see whether the fundus comes easily for the fundoplication to take so that we can do a good floppy fundoplication. We see how well the fundus is coming, and then we leave the fundus just to see whether it's not retracting back. If it is retracting back, we need some more resection. Next step is the posterior pleuroplasty, before which, as I said, we use a bougie. We insert a bougie and do a figure of 8 suture using a non-absorbable. We often use the silk tool in a figure of 8 pattern. Usually 2 sutures are sufficient to close the posterior pleura, but again it depends on how big the hiatus opening is. So after that comes the fundoplication, which is the main part. So here we will show a recent fundoplication, where initial sutures are taken between the 2 leaves of the fundus. And the second suture we often take with the esophagus. This helps in fixing the wrap, and the wrap does not slip or migrate into the fundus. And after the fundoplication is done, we fix it with the left pleura. So this fundoplicated part should not be very long. We should ensure that it is around 2 to 3 centimeters, and usually 2 to 3 sutures are adequate to perform a good floppy Nielsen's fundoplication. This is the final suture that is taken, and this forms a good enough 3 centimeter floppy wrap. And then, as I said, we fix it to the left pleura, so to prevent any migration of the wrap. Similarly, all the other steps remain same for the two-phase fundoplication. It's only that while doing the fundoplication, we do a posterior 270, where we take sutures through the fundus and through the esophagus on either side. One must be careful here that you don't take the vagus along. So just a word about robotic fundoplication. So basically the robot is friendly more towards the surgeon than the patient. The results are more or less equivalent, but it provides a wonderful view. The camera is so stable, it provides a 3D 4K vision, and tremor stabilization helps perform a good fundoplication while doing robotic. Rest all these steps remain the same. Finally, this is the updated SAGES treatment. So here, 4 questions were asked: medicine or surgery? This is my last one. Medicine or surgery? So if you want to treat chronic GERD, patient has trouble from reflux, long time, refractory to medication, go for surgery. Robotic or lab, still the studies are not good enough, not enough RCTs, except for few centers. And partial or complete, so again ask the patient, whether the goal is to minimize reflux, go ahead with a complete fundoplication, even in cases of ineffective esophageal motility, because it has been seen that a lot of these reverse after the surgery. And if the patient has concerns with dysphagia, you go ahead with the partial. This discussion has to happen with the patient. Divide short gastrics or not, we have already discussed. Whether gas bloat and long term, whether the patient wants new symptoms or not is what we need to know. So thank you, and I would like to give thanks to my mentor, Professor Rajendra Prasad from the All India Institute, under whom I trained in minimal access surgery. Thank you so much.
Thank you, Rajan. You can have a question. In GI, gynae, urology, head neck, now we are talking about cardiothoracic. So when you talk about robotic surgery for pancreatic and retroperitoneal tumors, if you go and find the data, there is limited data on that. But what I say, when you talk about robotic surgery for retroperitoneal tumors, these are the small tumors, maybe big tumors, and you have a limited space. But you need a bigger incisions and you need a lot of mobilization of the structures to take out the tumor. Even in a small tumor, but the mobilization is bigger one. So now you see the literature or the tumors of retroperitoneum, it can be benign or malignant. So normally it is malignant tumors, and there is benign tumors are less common, they are less than 20%, but more 80% are malignant. So this is all pathology like lipoma, myelolipoma, schwannomas, these are all retroperitoneal tumors. So now we divide retroperitoneal tumors mainly the deep retroperitoneal soft tissue tumors. Like soft tissue tumors, we say superficial and deep, but all retroperitoneal tumors are considered deep, and deep means they are considered advanced stage. Now this is staging less than 5 centimeter, more than 5 centimeter, superficial, deep. So depending upon T1, T2 and T3, we then stage in stage 1A, 1B, 2A, 2B, and then depending upon the size and depending upon the relationship to the structures like vascular structures or neural structures, we decide about surgery should be done or not. So most of the retroperitoneal tumors are very, very closely related to blood vessels or neural structures. So this is how we grade them, and grade is very, very important in staging and management of these tumors. So grade 1, 2 and 3 depends upon mitotic activity, differentiation, necrosis. So we grade them based on this, we make stage, like grade 1 is basically stage 1, grade 2 and 3 comes in stage 2 and 3. So now this is the most important part, we divide based on the resection, R0, R1, R2, R3. So basically every surgeon wants an R0 resection of retroperitoneal tumors, and which is the most difficult job, depending on the structures where they are situated. Can you do an R0 sections? Then you should go for surgery. That's why most of the surgeons recommend open surgery for most of the retroperitoneal tumors, because we want to achieve an R0 section. The management is surgery, radiation, chemotherapy and combined chemoradiotherapy, but till today the mainstay of treatment for all tumors is surgery. And en bloc surgery with complete clearance of margin is standard of care for all sarcomas. So now the approach is open laparoscopic robotic
and access is either you go intraperitoneal or retroperitoneal. Nowadays, retroperitoneal approach is coming in. Even for kidney cancers, we approach kidney through the retroperitoneal route rather than intraperitoneal. Until today, the open intraperitoneal approach is the most favored approach for most of the retroperitoneal tumors. Now, robotic approach is coming just to decrease the morbidity and mortality in retroperitoneal tumors. But when it started less than 3 centimeter. Now we talk about around 10 centimeter tumors can be taken out with this approach. So when you do open, you give a bigger incision as midline or rooftop incisions. We can go for thoracoabdominal or subcostal approach. So these are the maneuver needed by us when you do an open surgery like cattle brush maneuver, mainly for the right side structures, and Metox maneuver mainly for the left side structures. So now what are the pitfalls for open surgery? We give a major abdominal incision, more blood loss, delayed post-operative recovery, longer hospital stay, longer time to return to normal activities, loss of productive man hours, and more financial cost because patients stay in ICU or stay longer in hospital. Now, depending on the hospital structures, every day costs you much as compared to robotic instruments. Now, robotic surgery, one is the technological advancement, which is there with AI, like 3D technology, 7 degrees of freedom, more precision and control, meticulous dissections, better ergonomics, improved dexterity of the instruments, endurance instruments, 10-time magnification, and greater instrument stability. So these are the technical advantages with this technique. Now access to structures becomes more easy when you are going laparoscopically or you are going by a robot. So now just showing you a picture of a tumor. This is the tumor on the right side, basically this is the right kidney, the left kidney, and this is the right renal artery just going over the tumor. And this is the infrarenal IVC and the suprarenal IVC. So there is a tumor here, and you see in this picture it looks like some IVC is either thrombosed or IVC is, the tumor is going to the IVC. But you do some venography and just check there is no major vascular involvement, or if there is a vascular involvement limited, then you can go for surgery. But major vascular involvement is a contraindication for these surgeries. If you are a trained robotic surgeon, you can go for IVC resection also, but not an initial case to start with. So now you think about doing an open approach, or you think of laparoscopic approach or robotic approach. So what with the open approach, we say is the mainstay of treatment till today. When you thought of doing a laparoscopically, then very few laparoscopic surgeons said complete the procedure. The conversion rate is more to open when you do laparoscopically. When you go robotics, you are trained robotic surgeons and your instruments are more stable, your control is more, your precision more, you can complete the processes. So conversion from robotic to open is less as compared to laparoscopic to open. So these are my port placement for these surgeries, R1, R2 and R3 and 2 assistant ports. They are in the video. Can you run the video? Yeah. So this is what we say on the right side, cattle brush maneuver, mobilization of the right colon. And we are seeing the duodenum here. So now if the tumor is absolutely below the kidney, so you have to see the gonadal vessels and the ureter. So directly you have to go to the retroperitoneal structures. So you can see the fascia over the muscles of the retroperitoneum. So you first identify the tumor. You can see the renal artery here. Now this is the tumor. Whitish one. And the tumor is measuring around 5-6 centimeter. So you have to take care of the feeding vessels coming here from the retroperitoneum, and you have to take care of the lumbar veins, which is very, I say, one of the most difficult situations to control if there is any injury to the lumbar vessels. So you are doing surgery just very close to IVC. That's why we say the instrument control is must, and the best instrument control is with your robotic approach. Bipolar instrument on both the hands, on the left and right, makes your surgery avascular. So this type of retraction is possible only with the robotic instruments, and again the control is with the surgeon rather than the assistant. They are helping you in retraction. Surgeon is the one who is doing everything. Camera control, all instrument control is with surgeons. The assistant is helping you in suction and giving you gauze spaces during your surgery. So now this is a small tumor, maybe 5 or 6 centimeter. Access to this by an open approach will be a bigger abdominal incision. So this is the defect, and we put some fibrillar in the defect and just close it. So for these patients, the recovery is fast, the blood loss is minimum, return to normal activities is faster, and you can be discharged faster. So if you compare the cost with open and robotic approach, the robotic approach may look costlier, but when you see the total cost spent by the patient in 5 days or 6 days in open approach and 2-3 days in the robotic approach, cost almost comes similar. Next. So this, if I try to find out some literature about robotic approach for retrograde tumors, you will find limited data on that. And what it says, this is a comparison of around 88 patients, and what they did, open surgery, laparoscopic surgery and robotic approach, and they say the minimum time taken is with open approach, but the amount of blood loss is maximum with the open approach. And then you see the median duration of post-operative drainage, morbidity, post-operative length of stay was less with robotic approach. Convolutional wall was less significant in robotic group as compared to laparoscopy. And overall there was no post-operative mortality in any of the approach. And it says now, robotic approach can significantly reduce the risk in cases where the tumor is located hard to reach small areas, and when they are attached to main vessels and the size of tumor is less than 10 centimeter. So this is, you find very less literature on this. You can find case series, you can find individual cases of robotic approach for retrograde tumors, but if you want to find some robust data on that, you will not find that. So you have to select your patient wisely based on the location and the tumor size and its relationship to the structures. So now pancreas is an extraperitoneal structure, maybe you can say retroperitoneal. So now when you are a robotic surgeon, you start with abdominal surgeries. You can go for colorectal surgery, you can go for gastrectomies, you can go for radical cholecystectomies, but the last comes in our mind is the pancreas because it is one of the most morbid surgery, either we do by open, laparoscopic or robotic approach. So what we want a rapid recovery and we don't want an anastomotic leakage. So we have main defined steps for any pancreatic surgery, like right colonic flexor mobilizations, coccus maneuver, hilum explorations, right gastric artery division, right gastroepileutic division, duodenal division, cholecystectomy, CVD transections, GDA transections, first jejunal loop transections, pancreatic neck transections, or uncinate process. These are the steps. So we can mix up the steps. Some steps is done before and some steps later on, but these are typical steps in any pancreatic surgery. So now if you have a well-defined protocol of your surgery, like I'm going from 1 to 2 and 3, and then I can minimize my time and complications can be minimized. And then in the reconstructions like PZ and PZ depending on your expertise, hepatosesnostomy and pyroidosesnostomy or gastrosesnostomy. Next. So this is how we place our ports for any pancreatic surgery. Either this is in Whipple's or this may be a distal pancreatectomy. Can you run the video? So again the steps are like colonic mobilizations, then the duodenal mobilization. And again the benefit is mainly, I will say, the robotic instrument stability and your more control over the instruments. And 10 times magnifications makes your anastomosis easier, and endurance instruments movements makes the anastomosis easier. So this is the exposure of hilum. Take out the lymph nodes of the hilum, exposing the right gastric artery and sometimes GDA, gastroduodenal artery. And for me, lymph node dissection in hilum becomes easier with this approach as compared to my laparoscopic approach. The next step is to find out the portal vein and SASMV junction. This is division of gastroepiploic vein and artery. Now making a tunnel over the portal vein. Now division of stomach. Now you want to go for a pylorus preserving or you want to go in typical Whipple's procedure, depends upon the location of the tumor. The division of the pancreas. And finding out the pancreatic duct is much easier when you have 10 times magnification view. You can see the duct. So now the cholecystectomy, you can do it before dividing the pancreas or you can do after this. Now the division of the gastroduodenal artery. So either you can use a stapler, vascular stapler, or you can put clips. So once the resection part is done, then you do a pancreaticogestomy in typical standard steps, 4-layer anastomosis. And much easier than your open approach. You can take 5 sutures to make an anastomosis. Then continuous layer hepatocogestomy. So you can see how we move the instruments by the robotic instruments, much easier with robotic instruments as compared to laparoscopy, gastrojejunostomy, stapled one. Next one. So this was typical pancreatic surgery, Whipple's operation. Now you have a distal pancreatic tumor going to the splenic hilum. There is a 10 centimeter tumor at the tail of pancreas and going to the splenic hilum. So now this approach is what we say the radical proximal to distal pancreatospleniectomy, and this is the tumor. So you have to expose the tumor. You go over the sac, expose the tumor, expose the vessels, splenic artery and vein. So now if you want to open approach, you have to give a bigger incision in the upper abdomen. But with a robotic approach, you mobilize it and then you take out the specimen to the lower abdominal incision, which are easy to manage and they are smaller incisions. So we can see here, we will see the splenic vein here. So this is pancreas. We are going below the pancreas and we can see the splenic vein. And we are identifying the splenic artery. This is the splenic vein and this is splenic artery. So once you identify the splenic artery and vein, you can divide the vein and the artery and the pancreas. And then you mobilize the spleen. And short gastric vessels will be divided so that we can do the splenectomy. Splenic vein, putting a stapler on splenic artery and vein. Now division of the pancreas, this is the pancreatic tail. So mobilization of the tumor now along with the spleen. Short gastric vessels. Splenocholic ligament. So underlining the pancreas to avoid any pancreatic leak in post-operative period. So these are the typical steps as you do in pancreatic surgery but done by robotic approach. And they are safe, this is feasible, but again you need a good training for any pancreatic surgery because the most complicated surgery in abdomen we think about pancreatic surgeries. Thank you so much.
Thank you, Dr.
Not like we are doing.
But you sit down in the console, isn't it? You just monitor from the console, isn't it? All this surgery.
We are on the console, like when you do a pancreatic surgery, sometimes you do the resection with robot and then do the anastomosis with open. So what we are doing is total robotic approach. So it is, we say robotic assisted approach because we are the one who is running the robot. So robotic is helping us. So it's not typically robotic surgery, that robot is only one doing that.
So that's what it clarifies.
So that is a master-slave technology. We are the master and robot is a slave.
But I think that the new conception of AI is that this is what called that autonomous robotic surgery. You don't have to do anything. The robot does everything.
So before that it has been tele-robotics, before the fully robotic comes. So tele-robotic means I'm sitting here doing surgery somewhere else.
Yes.
So that is coming in view now, and people have started doing urology surgery by tele-robotics now. So maybe in future, maybe down the line, 2-3 years, people will start doing tele-robotics.
Anyway, there's a new invention coming up probably that makes surgeons lazy and out of the practice.
So that's the reason why people are talking about robotic, because a lot of things will happen which we don't know.
No.
So if we don't start today, maybe in future we'll think why we would started in the past.
That's a message that should go now, I think. Thank you very much, sir.
Thank you, sir.
By 2040. So we should all be aware of cancer. We should all be geared to treat cancer much more than we ever was. And this is the chart that reflects what is going on differently between us and the West. If you see the chart on the right, the incidence is going down, the mortality is going down in the West. But in a country like India, we are still on the up curve. The incidence is increasing, the mortality is still increasing. So we need to do something seriously. GI cancer is even more challenging. Why so? Incidence is high in Indian subcontinent, lack of symptoms to begin with, lack of any reliable screening test. So we have very high case fatality rate for GI cancers. Now, what are the newer frontiers? I think Tawas has done my job a lot easier by showing that how robotic